Now let's talk about ankylosing spondylitis. So it's ankylosing spondylitis. Let's watch a video first. Ankylosing spondylitis. I think there's a video by Jordu. Okay, let's watch this video. Sorry for the ads again, guys.
12 great fruits, nuts, and seeds for energy cycle. Nato power breakfast.
I think we need to remove these ads.
The name ankylosing spondylitis can be broken down. Ankylosing means stiff, heavy. Spondylosis refers to the and ankylosing means inflammation. So ankylosing spondylitis. But it also causes inflammation in other parts of the body, like the eyes and blood vessels. Ankylosing spondylitis is also called vector disease. It's primarily
Okay, so what's the pathogenesis of ankylosing spondylitis? Is the altered gut biome or defective mucosal barrier. So increased production of interleukin 17 and of alpha and prostaglandins occur, and there is increases with SLB27 types, SLA types. So clinical finding inflammatory back and bottom pain, incidence onset less than 40 years of in adults. Adults with back pain usually have ankylosing spondylitis related with exercise but not rest. Okay, nostril pain occurs, reduced sense expansion and spinal mobility, enthesitis, dactylitis, and uveitis, all of them occur. Inflammatory signs like CRPNES are raised. Sacroiliitis, bony erosion, subchondral sclerosis, and ankylosis can occur. Bony ankylosis can occur. Syndesmophytes can be present. Osteopetrosis and Bambuspan can also be present. Okay. A patient with chronic pain and stiffness of the spine and reduced spinal mobility likely has ankylosing spondylitis. The pain in AS is generally better with activity and worse at night and with rest, which can lead to disrupted sleep and daytime fatigue. Ankylosing spondylitis is characterized by bone erosions and excessive formation of new bones in the exoskeleton, primarily on the vertebral margins. Okay, patients with AS should undergo X-ray of the spine, which shows which I can see in the diagnosis. X-rays of pelvis shows inflammatory arthritis of the sacral legs, and so sacroiliitis can be seen visibly as joint erosions with subcondylar sclerosis. So similar to any forms of osteoarthritis, there can be some joint erosions with subcondylar sclerosis can occur. These findings are relatively specific for spondyloarthritis, and in association with typical symptoms are often adequate for diagnosis. These are progressive, the joint space is obliterated and bony ankylosis occur. Similarly, spinal X-ray may show heterotopic ossification affecting the margins of the vertebral bodies, which are bridging syndesmophytes. So a spinal X-ray can show bridging syndesmophytes. Advanced and continuous syndesmophyte formation is called bamboo spine. Okay, so this is how the sacroiliitis looks on the X-ray. So this is it. Bamboo spine. So fusion of both syndesmophytes can occur. Facet joints can occur. This lead to bamboo spine. Okay, yes, it's seronegative spinal arthropathy. There is no seronegative test to confirm diagnosis. Although most cases are associated with HIB27, most patients with HIB27 never develop AS, so this marker does not confirm the diagnosis. Patients often have elevated ESR, CRP, abnormal blood counts, anemia, leukocytosis can occur, but these are non-specific. Non-conduction studies are typically used to identify peripheral nerve lesions in the patients with deficits on neurological examination. This patient has normally exams findings of electrodiagnostic would have little utility. RF is used in diagnosis of rheumatoid arthritis, which typically occurs at age more than 40 and is common to women, is more common in men. RA usually causes symmetric peripheral arthritis. Subacute involvement can occur, but the lumbar spine is usually spared. Okay, cycloxanil inhibitors. So there is COX-1 and COX-2. So COX-1 can be inhibited by aspirin, which inhibits COX-1 irreversibly, and NSAIDs are also another thing that another drugs that inhibit COX-1. While COX-2 inhibitors, there are some selective COX-2 inhibitors like rofecoxib, which can decrease formation of inflammatory mediators by COX-2 pathway. So constitutive prostaglandins can be inhibited by COX-1. Inducible prostaglandins can be inhibited by COX-2. So constitutive prostaglandins include those prostaglandins which have physiological functions, while inducible prostaglandins have those with physiological functions as well as pathologic functions. Okay, gastric mucosal protection. Okay, renal perfusion and protection. All three of them. So in the gastric mucosa, there is mucus producing mucus with rich in prostaglandins. So similarly, renal perfusion is included prostaglandins, also vasodilation, and prostaglandins also helped by prostaglandins. Physiologic function, besides physiological function, inducible prostaglandins also cause pain sensitivity and inflammation. Prostaglandin synthase, cycloxanil initiates the synthesis of prostanoids, prostaglandins, thromboxans from arachidonic acid. COX exists in two primary forms: COX-1, which is physiological, and COX-2, which is expressed the site of inflammation. NSAIDs inhibit COX-2, decrease prostaglandin synthesis. Most NSAIDs inhibit both COX-1 and COX-2 enzymes. So, however, inhibition of COX-1 may lead to severe adverse effects, including gastric ulceration. So, COX-1 lead to gastric ulceration and increase in bleeding. So, decreased platelet aggregation. So, increased bleeding as well as gastric ulceration can occur because of just giving COX-1 inhibitors, while selective COX-2 inhibitors and celecoxib have potent anti-inflammatory effects with less risk of bleeding and GI ulcerations. They're recommended for use in patients with at risk for gastrointestinal complications like those with prior peptic ulcer disease. The risk for ulcers can also be reduced by combining NSAIDs, non-selective NSAID with a selective drug, PPIs, to reduce gastric acid secretion. Okay, so there is permanent phospholipid, which when exposed to phospholipase A2 gives, so phospholipids in the cell membrane gives for arachidonic acid, which can occur under two different pathways, COX-1 and COX-2, which produce prostaglandins. So they are both prothrombotic state produced by thromboxane A2, and antithrombotic effect produced by prostacyclins, and edema formation occurs, that inflammation occurs because of edema, prostaglandin D2 and E2. So in the prostaglandin pathway, while lipoxygenase pathway can produce anti-inflammatory as well as pro-inflammatory cytokines. So anti-inflammatory cytokines are lipoxygens, lipoxygen A4 and D4, while pro-inflammatory cytokines are leukotrienes C4, D4, and E4, as well as B4, which also help in chemotaxis. So they are all produced by 5-HPETE. Okay, selective COX-2 inhibitors do not have substantial effect on serum lipids. Both COX-1 and COX-2 are expressed in renal tissues. They have therapy with either non-selective NSAIDs or selective COX-2 inhibitor can cause fluid retention, aggravation of hypertension, and impaired renal function. So they must be given very cautiously. COX-2 is expressed in vascular endothelial cells and vascular smooth cells, where it plays a role in local production of prostacyclin. So COX-2 is also expressed in endothelial. So there is a endothelial cells in the blood vessels. So endothelial cells and small muscle cells in the blood vessels. Prostacyclins are produced via COX-2 pathway, which has anticoagulant and vasodilator reactions. So they have anticoagulant and vasodilator reactions, and COX-2 inhibitors have been associated with an increased risk of cardiovascular effects. So COX-2 inhibitors, when given, have so etocoxib, celecoxib can have cardiovascular effects because some of the blood vessels, the endothelial cells and vascular smooth cells, which is anticoagulant in nature, is not produced because of COX-2 inhibition. Okay, and therefore, some cardiovascular manifestations can occur. So platelets form thromboxane A2. So platelets have COX-1 enzyme, so which helps in production of thromboxane A2, which helps in platelet aggregation and hence relating thrombosis, while endothelial cells produce COX-1 and COX-2. So COX-2 is also produced, so prostacyclins which inhibit platelet aggregation, so and cause vasodilation. So prostacyclin is cause vasodilation, while thromboxane A2 cause thrombus formation, and thrombus formation cause vasoconstriction, while prostacyclin is just opposite in nature. Now, scaphoid avascular necrosis. So, scaphoid avascular necrosis. So there's a radial artery in the extensor surface of the hand. So radial artery comes off and gives rise to some branches. So this is a dorsal scapular branch, scaphoid branch. So there's a dorsal scaphoid branch of the radial artery. So this is a radial artery, and there is a dorsal. So in the dorsal surface, there is a dorsal scaphoid branch, which has some retrograde blood supply as well. So if there is a fracture of the proximal pole of the scaphoid, so if there is fracture of proximal pole of scaphoid, then the retrograde blood supply is damaged. Therefore, distal surface of the scaphoid is supplied by the radial artery, but the proximal surface is not. So scaphoid fracture, if occurs, decreases the blood supply to the proximal surface of the scaphoid bone, and dorsal carpal branch, palmar scaphoid branch. So palmar and dorsal scaphoid branch are present. In the dorsal surface, the deep arteries goes inside the scaphoid retrogradely, in a retrograde fashion. Therefore, FUSH can cause scaphoid fracture that can lead to a vascular necrosis of the proximal part of the scaphoid. Scaphoid fractures are most common carpal bone fractures, frequently known for FUSH injury that cause direct axial compression of or hyperextension of the wrist. So there is direct axial compression. So axial compression of the wrist or hyperextension of the wrist can occur. Scaphoid fractures we suspect in patients with persistent wrist pain and tenderness in the anatomical snuff box. So if there is pain in the anatomical snuff box, then a shallow triangular depression of the dorsal wrist defined by the following border. So what is the border? What are the borders for anatomical snuff box? So in the medial side and then the lateral side there is a thumb. So in the medial side there's a thumb like, and there's extensor in the extensor surface of the hands. There is anatomical stump box, so therefore extensor muscles are present. So first, in the medial side, or let's say in the index finger side, there is a tendon for extensor pollicis longus. So there's a long tendon for which is called extensor pollicis longus. Okay, in the lateral side, tendons for the abductor pollicis longus. So tendon for the abduction. So abductoring tendons are present. So abductor pollicis longus and extensor pollicis brevis. So abductor pollicis longus, extensor pollicis brevis are present laterally, while in the middle side there is extensor pollicis longus, abductor pollicis longus, and extensor pollicis brevis. So now in the proximal surface, there is a stellate process of the radius. So in the proximal surface, there is radial artery with stellate process of the radius, while in the floor there is scaphoid bone and trapezium bone. So scaphoid and trapezius bone are present in the base. Okay, the main supply of the scaphoid is provided by dorsal scaphoid branch of radial artery. This enters the bone's distal pole and then processes in the retrograde manner to provide blood supply to the proximal bone. Because fracture of the scaphoid can easily interrupt the retrograde flow, so it is a risk of vascular necrosis. So yeah, scaphoid fracture looks like this. So C looks too pretty, means scaphoid bone. So scaphoid in the lateral side. C looks too pretty. Try to catch her. So P and H are near. So P and Muhammad are nearer. So That is how we identify it. So anaphylactic snub box is formed by extensor pulsus longus in the medial surface, extensor pulsus brevis or abductor pulsus longus in the lateral part, scapular bone on the base, and extensor retinaculum from which radial nerve passes through, abductor pulsus longus. Yeah, okay. Carpal tunnel syndrome is caused by median compression of the wrist within the carpal tunnel. So there is median compression at the wrist within the carpal tunnel. It is most commonly non-traumatic in origin, but when it does occur following trauma and due to push, it is typically due to palmar dislocation of the ligament bone into the carpal tunnel space. Okay, palmar digital branch of medial nerve. Trapezium is present here, so palmar is now the medial nerve. So this is a median nerve. So this is radius, and this median nerve is present here. So this is median nerve, and so in the median nerve above the carpal tunnel, there is palmar cutaneous branch of the median nerve. Therefore, does not impair the cutaneous supply, while below the carpal tunnel, which is present besides or behind the transverse carpal ligaments, transverse carpal ligaments, so transverse carpal ligament, which is flexor retinaculum, median nerve passes the motor function of motor supply of median nerve passes, and so the introduction symptoms. Acute compartment syndrome occurs when increased pressure within the facial compartment, that is intercompartmental bleeding, muscle swelling, compromised blood circulation within the space. It typically develops after significant trauma, particularly long bone fractures of the leg or forearm. The potent contracture is a slowly progressive fibroproliferative disorders of the palmar fascia. So this dupotent contracture refers to the fibroproliferative disorders of disease of the palmar fascia. So there's a palmar region, the palmar fascia is present here, and it's slow and progressive fibroproliferative disorder. So because of fibrosis of the palmar fascia, so dupotent contraction and outward nodules form on the fascia, eventually resulting in the contractures that draw the fingers into flex them. All right. Okay, there are several. So this is a typical sign of dupotent contracture. And Guyon's canal syndrome is caused by compression of the ulnar by the wrist within the Guyon canal. So there's a Guyon canal. So Guyon canal is present from that joins the hook of the hamate. So from the hook of the hamate to the pisiform bone. So from the hook of the hamate to the pisiform bone, there's a canal which is called Guyon's canal. There's a ligament that covers a canal called Guyon's canal from which ulnar can pass. And this is normal, while pinched ulnar occurs in this because of Guyon's canal. So Guyon's syndrome of compression of the ulnar of the wrist in the Guyon canal can develop following refraction of the push. It can always push, but typically occurs due to refraction of the hook of the hamate. So hook of the hamate, if ruptures, can lead to Guyon canal syndrome. All right. So yeah, muscle fiber characteristics are slow and fast muscle types. Slow means slow twitch muscle fibers are what are those muscles which help in maintaining the posture of the body. So they undergo oxidative phosphorylation, while type 2 muscle fibers which are rich in myoglobin are which are low in myoglobin because of less oxygen undergo glycolytic pathway, so or anaerobic pathway for generating energy. So if you want to, for a marathon runner, type 1 fibers are very important because they generate sustained force and they are enduring. So, but in the type 2 require heavy weight lifting. I would require type 2 fibers, and they're anaerobic. So yeah, force energy is high in the anaerobic or type 2 muscle fibers. They're resistant to fatigue, so the posture is can be maintained at all times. So there is less resistance glycogen, but lipid content should be high. So lipid produces high amount of ATP or energy. So in type 1 fibers, so there must be high amount of lipid content, while low amount of lipid content is present in type 2 fibers, while glycogen content is low in type 1 and high in type 2 fibers because it has to generate ADP time and again. Mitochondrial content is high and oxidative pathway, glycolytic pathway occurs, it is red, and the prototype is soleus. Soleus muscle is type 1 fiber, so soleus is type 1 fiber, triceps which helps during lifting, weightlifting is a example of type 2 fiber. Body's muscles are composed of two main fiber types, that is slow twitch or type 1 fiber, and fast twitch means type 2 fiber. So type 1 fiber performs actions requiring low level sustained force, example postural maintenance. So postural maintenance and functions primarily via aerobic metabolism. So functions via aerobic metabolism, meaning they have high myoglobin oxygen storage and mitochondria fermentation. The soleus muscle of the leg and the parasternal muscle of the back and postural muscle predominantly comprise of type 1 fibers. Type 2 fibers are specialized for generating rapid force movement and they fatigue quickly. They derive energy from glycosenolysis and subsequent anaerobic glycolysis. Muscles that maneuver the upper extremities are permanently raised toward rapid force movement and are more likely to have a high percentage of type 2 rather than type 1 fibers. Okay, muscle depolarization. Okay, so it's a healthy muscle cell where action potential comes in comes in, and from the transverse tubule, calcium enters inside the cell, the muscle cell, and calcium is released evenly at all in all parts of the cells. And this is nucleus, this is a myofibril, sarcoplasmic reticulum with stored calcium, sarcolemma. So this is a membrane of the cells. So fewer transverse tubules. So fewer transverse tubules means fewer amount of calcium goes inside the cell, resulting in uneven calcium release at uneven sides. Therefore, leading to uncoordinated action contraction. So because of fewer transverse tubules, so fewer transverse tubules means contraction occurs only at the surface levels of the cells, while not in the very inner part of the muscle. So transverse tubules, T tubules are invasive inside the muscle cell membrane, sarcolemma located in close proximity to the terminal cisterns of the sarcoplasmic reticulum. So they are present in close proximity to the terminal cisterns. So terminal cisterns, so they are found in striatal muscle, that is cardiac and skeletal muscles, and contain voltage-gated alpha calcium channels, dihydropyridine receptors. So dihydropyridine receptors are present. Pyrimidine receptors are present adjacent to the ryanodine receptors on the terminal cisterns. So in the terminal cisterns, where is the terminal cistern? So terminal cistern. At the terminal cistern, the ryanodine receptors are present, while in the voltage-gated alpha channel, the dihydropyridine receptors are present, adds to the ryanodine receptors on the terminal cistern. So in terminal cisterns have ryanodine receptors, while striatal muscles contain the calcium channel types are dihydropyridine receptors. So during muscle contraction, T tubules are other represent depolarization impulse to rapidly propagate through the interior of the muscle fibers. The T tubule arouse the rapid depolarization of the impulse to rapidly propagate through the interior of the muscle fiber. This ensures that calcium release from the sarcoplasmic reticulum occurs uniformly throughout the fiber, allowing for synchronized contraction of myofibrils in its muscle cells. So it causes depolarization to the interior of the muscle fibers, and calcium release from the sarcoplasmic reticulum occurs throughout the fibers uniformly. Therefore, synchronized contraction of the myofibrils occur, while this patient most likely has a form of limb girdle muscular dystrophy. So this is something called limb girdle muscular dystrophy. So there's something called limb girdle muscular dystrophy. Okay, so limb girdle muscle dystrophy and mutated sarcolemma protein that are cateolin. So there is something called sarcolemma protein, mutation of sarcolemma protein, which is example cateolin mutation, affects excitation contraction uncoupling, coupling. It affects it, and decrease of number of functional T tubules affecting the muscle fibers lead to uncoordinated contraction of the myofibrils, which muscle manifests as muscle weakness. So limb girdle muscular dystrophy manifests the weakness because of uncoordinated muscle contraction, because of T tubules are asynchronously activated. Activates the muscle fibers synchronously. So intracellular calcium regulation occurs. So this is sarcolemma or membrane or surface or cell membrane of the muscle fiber, the cytoplasm, and in the T tubule. So in the T tubule, so there's a protein. There's a channel they are called calcium channel, which is the L type of calcium channel, which goes inside the sarcoplasmic reticulum. Sarcoplasmic reticulum has ryanodine receptor in it, which helps in releasing the stored calcium from inside the cell to outside. This calcium now goes and assists in myofibril contraction. So they bind to troponin C. So troponin C and helps in ATP synthesis, ADP formation, which helps in contraction. So decremental force generated on repeated stimulation characterizes myasthenia gravis and autoantibody disorder inhibiting postsynaptic SL1 receptors in the neuromuscular junction. A constant low response to repeated nervous stimulation is more likely if T tubules are lacking. ATP fuels myosin movement, so ATP. So there's something called ATP. It fuels myosin movement along the actin filaments, causing contraction. So ADP fuels myosin movement along the actin filaments, causing contraction, and drives the pump that transport calcium back into the sarcoplasmic reticulum. So ADP opens the channels in the ryanodine receptors, which move the calcium back into the calcium channel into the endoplasmic sarcoplasmic reticulum, causing relaxation. McArdle's disease is one of the impaired, is a glycogen storage disease, which causes impaired ADP production and occurs due to failure of muscle glycogen breakdown. So there is failure of muscle glycogen breakdown. So failure of muscle glycogen breakdown. So there's no breakdown of the there's no breakdown of muscle fibers, and therefore glycogen breakdown does not occur. So ADP is not generated. So lack of ADP generation does not cause contraction of the muscle. So it causes muscle relaxation. Impaired relaxation after a sustained contraction. It causes sustained maybe contraction. Impaired relaxation after sustained contraction occurs in myotonic dystrophy due to trinucleotide repeat expansion altering myotonin protein kinase. So impaired relaxation after sustained contraction occurs and relaxation does not occur. So in myotonic, so the name itself sustained implies myo means muscles and tone means tonic. So alterate always contraction of the muscles occur because of lack of relaxation mechanism because of trinucleotide repeats because of trinucleotide repeat that alters myotonin protein kinase. This protein facilitates myosin head detachment from the actin filament to enable muscle relaxation. T-tubules do not play the role. Mutation in troponin C block its response to intercellular calcium and prevent muscle contraction. So if there's a mutation in troponin C, it can block its response to intercellular calcium. So troponin C does not now react to intercellular calcium and prevent muscle contraction. However, muscle fibers with decreased number of tubules will maintain limited contractility. So calcium modulation of actin binding sites. So myosin binding site are blocked. So you see, this is actin, okay? So this is actin, this is actin, this is actin, and this is actin. These are actin filaments. Okay, so actin filaments are bound by a rope-like structure. So this is a rope-like structure. This is a rope-like structure which is tropomyosin. So tropomyosin. It's a rope-like structure which is tropomyosin, and in the tropomyosin and the actin filaments junction, there is a troponin complex with troponin A, troponin C. So troponin C is present in the tropomyosin actin troponin complex region. So troponin complex, calcium complex pulls tropomyosin also. When calcium enters the cell, so when calcium enters the cell via T-tubules, it goes and binds to troponin. So calcium, let's say it's red in color, so this is calcium. So calcium goes and binds to the troponin complex, calcium troponin complex. So calcium troponin, this is something called troponin C. So troponin C calcium complex form, and they pull they pull the tropomyosin away from the sites, releasing the actin filaments, exposing the myosin binding site. So there is a myosin binding site as well. So in the actin filaments now pulls tropomyosin away, exposing the myosin binding site. So myosin binding site. These are tropomyosin. Tropomyosin means troponin which hide the myosin binding site. So tropomyosin uh, hides the myosin binding sites, and when calcium enters the cell, it binds to myosin. So it's troponin C, and troponin C now they collectively open the myosin binding sites where actin myosin binding sites. These are myosin binding sites. Okay, myosin binding sites where actin binds now. So where actin binds here and cause contraction of the muscle fiber. Okay, understood, babies. Okay, Sjogren syndrome. So we'll be now talking about Sjogren syndrome. So let's watch a video. Sorry for the spelling. I think this will be okay.
Hey everyone, this is Rheumatology Sjogren's syndrome. Sjogren's syndrome is a chronic autoimmune disorder causing three characteristic symptoms. One is keratoconjunctival sickle or xerophthalmia. The second one is xerostomia, and the third one is arthritis. So there is a triad of symptoms. The three symptoms are dry eye, so xerophthalmia. The second is dry nose, so xerostomia, and the third is arthritis. Now, women generally outnumber men with this condition, and it usually occurs with an onset between the ages of 40 and 60 years old. It is caused by lymphocytic infiltration of salivary and lacrimal glands. And here is a picture of some of the lymphocytic infiltrations you can see here. There are two types of Sjogren's syndrome. One is considered primary. Primary Sjogren's syndrome is Sjogren's syndrome that is not associated with another condition. And secondary Sjogren's syndrome is secondary to another condition. Some of those conditions can include rheumatoid arthritis, lupus, and HIV. Now, when we look at the clinical manifestations of Sjogren's syndrome, we generally split it into glandular and extraglandular manifestations. The glandular manifestations are those sinus symptoms. So sinus symptoms are those dry symptoms. So dry eyes and dry mouth. Some of the complications from having dry eyes is you have increased risk for nephritis and inflammation of the eyelids, generally due to infection by staphylococcus. The dry mouth increases the risk for endocarditis, candidiasis, and arthritis. The extraglandular manifestations include arthritis and arthritis. So that would be the third symptom in our triad of Sjogren's symptoms. But it can also include other symptoms, sinusitis, biomet, or interstitial pharmacies, if you have a full pattern. You can use your own treatment, so dry is treatment. There's an increased risk for glomerulonephritis. Now, what can also occur as an extraglandular manifestation of Sjogren's? Vascular disease is called peripheral neuropathy. And having Sjogren's increases the risk of neurotoxicity from your eye and lymph.
Okay, so immediate destruction of lacrimal and salivary glands. Okay, also arthritis together is called Sjogren syndrome. For the primary disease and secondary with autoimmune disorders like SLE and RA. So dry eyes occur, dry mouth occurs, there's stamina, xerostomia, salivary hypertrophy, and dry skin, xerosis can occur, and Raynaud's phenomena and cutaneous vasculitis can occur with positive Rho and La antibodies. So anti-Rho, anti-La antibodies, and complications include monocytic lymphoma, corneal damage, and caries, etc. This patient with chronic dry mouth, so chronic dry mouth, and palpebral salivary gland, so palpebral salivary gland enlargement has extensive lymphocytic infiltrate with the terminal center on salivary gland biopsy. So there are extreme lymphocytic infiltrate with the terminal center on salivary gland biopsy consistent with Sjogren syndrome. It is an autoimmune disorder carried by lymphocytic infiltrate in the exocrine glands. It presents with dry eyes, keratoconjunctivitis sicca, and dry mouth, xerostomia, extracorneal manifestations. The arthralgias and cutaneous vasculitis can also occur because of deposition of circulating immune complexes. Complications of assessment include corneal ulceration, they do lacrimal gland function, and increase in dental caries, risk of candidal caries due to diminished salivary gland function. The chronic B lymphocyte stimulation in Sjogren syndrome also predisposes patients to melanin transformation, causing non-Hodgkin's lymphoma. So because of you know lymphocytic infiltration or multiple multiplication of lymphocytes, NSL can occur. Marginal lymphoma, diffuse large B cell lymphoma are very common. So this is our middle center. So this is our middle center of the lymphocyte. These are lymphocytic infiltrates. So lymphocytic infiltrates surround the germinal center. So this is germinal center. This is surrounded by lymphocytic infiltrate. So this is a cerebral gland excisional biopsy. SLE is treated with this for arterial and venous thrombosis. So SLE has a risk of arterial as well as venous thrombosis due to autoantibody production, antiphospholipid antibodies. So SLE has more of antiphospholipid antibodies. Patients with this also have arthralgia and anemia, but right northern peritoneal enlargement in association with characteristic biopsy finding are more characteristics of Sjogren syndrome. Atlantoaxial subluxation, the displacement of C1 and C2 vertebrae, is caused by ligamentous deterioration in the cervical spine. It can be seen in a variety of inflammatory disorders like rheumatoid arthritis, ankylosing spondylitis, psoriasis. So atlantoaxial subluxation, displacement of C1 and C2 vertebrae is caused by ligamental distortion and deterioration in cervical spine. So this can be seen in a variety of inflammatory disorders like rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, but not common in Sjogren syndrome. So atlantoaxial axial subluxation is common in RA, AS, and psoriatic arthritis, but not in ASS. Renal arterial stenosis is common context in case of advanced atherosclerosis or fibromuscular dysplasia, and often causes treatment-resistant hypertension. Okay, restrictive cardiomyopathy is often idiopathic and can be associated with infiltrative disorders. So like amyloidosis, sarcoidosis, and hemochromatosis are all of these three depositing in the heart muscles cause restrictive cardiomyopathy. And cardiac manifestations of Sjogren syndrome are rare and do not include restrictive disease. So Sjogren syndrome do not have any cardiac manifestations. Sometimes interstitial lung disease can occur. Okay. Now let's talk about type 2 hypersensitivity. Type 2. I think Osmosis has a very good video on it.
Having a hypersensitivity means that the immune system is reacting to something in a way that damages the body rather than protecting it. There are four different types of hypersensitivities. The second type, type 2 hypersensitivity, is sometimes called cytotoxic hypersensitivity because a lot of disorders caused by this hypersensitivity involve antibody-mediated destruction of the cells. These disorders can be tissue-specific, meaning that the antibodies are generally specific to one type of tissue or organ. There are other antibody-mediated hypersensitivities that are systemic, but these are generally type 3 hypersensitivities. So our immune system is amplifying anything that's considered not self-right, anything that's not self-right. This works in part because of a process called signal tolerance, which is when the immune cells that are self-reactive destroy the antibody. failure cause cell death in an apoptotic or quiet death sort of way, such that there's no surrounding inflammation. Okay, so far all the mechanisms of led to cell death are cytotoxicity, right? There are, though, non-cytotoxic type 2 hypersensitivities as well, where the antibody just sort of disrupts function, called antibody-mediated cellular dysfunction. Sometimes when an antibody binds to antigen, it just sort of gets in the way. When it's happening, it can change the way a cell's supposed to function. This is the case in the autoimmune disease myasthenia gravis, where antibodies specifically acetylcholine receptor in muscles simply blocks the binding of acetylcholine, which causes the muscles to not get stimulated and progressively weaken over time. This mechanism is also involved in Graves' disease, where antibodies target receptors that stimulate thyroid hormone production. But in this case, they not only get in the way, they actually activate the receptors, causing overproduction of thyroid hormone, or hyperthyroidism. And we have a handful of different ways that antibody binding to cells can cause them to get destroyed or become less effective. The important thing to remember about type 2 hypersensitivity is that they're antibody mediated. They generally lead to cytotoxicity, and it's tissue specific.
Okay, the patient's clinical finding of intermittent diplopia, okay, difficulty chewing, and speech problems, especially at the end of the day. So, they also is diagnosis of myasthenia gravis, which is a type 2 hypersensitivity reaction. So, it's caused by impaired function of the nicotinic cholinergic receptor at the neuromuscular junction due to interference by IgG and autoantibodies. The diagnosis can be confirmed with administration of anticholinesterase ASN that increase the amount of acetylcholine in the neural plate, neuromuscular junction, causing the increased amount of acetylcholine in the neuromuscular junction. So acetylcholinesterase activity decreases at the lower temperature. So acetylcholinesterase activity decreases, okay, at lower temperature. So application of ice pack can also improve symptoms are caused by weakness of superficial muscle, like example ptosis. Myasthenia gravis is a type 2 hypersensitive reaction which is characterized by IgM or IgG autoantibodies that bind to cell surface antigen or extracellular matrix component. Among the available options, only good Pasteur syndrome is due to the production of autoantibodies directed against global basement membrane. This antibody causes internal destruction of the basement membrane in the lung alveoli and the glomeruli. Atopic dermatitis is a pure pruritic eczematous skin condition that almost always begins in childhood. The pathogenicity involves several factors including skin barrier abnormalities, defects in innate immunity, and T type 2 helper 2 cells, skewed immune response. So atopic dermatitis is a chronic pruritic eczematous skin condition. So atopic dermatitis is a chronic pruritic eczematous condition that occurs in childhood. It includes skin barrier abnormalities, defect in innate immunity, and type 2 cells, helper cells, skewed immune response. The pathogenesis of contact dermatitis, that is, contact dermatitis is a type 4 hypersensitivity reaction, involves cutaneous exposure to small foreign antigens like haptens that bind to skin proteins. These proteins are subsequently processed by antigen Langerhans cells that transport the modified proteins to lymph nodes and promote the development of hapten-specific T cells, which continued hapten exposure sensitive T cells produce inflammatory cytokines at the exposed site, causing characteristic eczematous skin changes. Alright, most patients with acute hypersensitivity pneumonitis have specific serum IgG antibody that precipitates bacterial or fungal antigens found in inhaled organic dust particles. This causes interstitial alveolitis and bronchiolitis by immune complex and complement deposition in vessel walls, type 3 hypersensitivity mechanism. The pathogens of PSZN in acute hypersensitivity pneumonitis, okay, there are specific serum IgG antibodies that precipitate bacterial or fungal antigens found in inhaled organic dust particles. We found, hypersensitivity pneumonitis have specific serum IgG antibodies that are in the blood that precipitate bacterial fungal antigens found in inhaled organic dust particles. This causes interstitial alveolitis and bronchiolitis by immune complex and complement deposition in the vessel wall, that is type 3 hypersensitivity mechanism. So, hypersensitivity pneumonitis is a type 3 hypersensitivity reaction. Okay, the pathogens of PSZN involves granular deposition of immune complex containing group A stratical antigen IgG and C3 in the glomerular membrane and mesangium. Is a type 3 immune complex mediated hypersensitivity response. Okay. Let's talk about Paget's disease of bone. Okay, so Paget's disease of bone has osteoclastic activity, osteoblastic activity, and all the three activities. Okay, so osteolytic phase is osteoclastic dominant, and osteoclasts are retreated, which destroys the bone, while mixed phase has both osteoclast and osteoblast, and the osteosclerotic phase is more thick woven bone is formed. The patient's bone pain. So if there is a bone pain, increase ALP and biopsy findings. So biopsy findings are characteristics of disease of bone. So PDB, a condition that results in accelerated bone remodeling with eventual bony overgrowth. The disease is thought to be caused by environmental factors and gene mutations. So, a gene mutation, for example, affecting a rank ligand or osteoproteaserine that result in recessive rank and NF-kappa B activation. This leads to increased osteoclastic differentiation and activity. The disease typically progresses through three phases. Osteolytic phase, characterized by increased number of osteoclasts that appear abnormally large with an excessive number of nuclei. Increased resorption activity is prominent. Increased resorption activity is prominent. So mixed osteoclastic stains or different progressive rapid increase in osteoblastic bone formation with persistent osteoclastic activity. This newly bone is abnormal with interspersed area of disorganized laminar and woven bone. Osteosclerotic phase is osteoblast dominant, which is characterized by continued osteoblastic bone formation and remodeling that result in dense hypovascular mosaic pattern of laminar bones with irregular haphazardly oriented sections separated by prominent cement lines. So separated by prominent cement lines are also present. So osteoclastic differentiation. So the result in this thickened deformed bone that is weaker than normal upon fraction. So osteoclast differentiation occurs by in the hematopoietic stem cells. This is a hematopoietic stem cell that can form any sorts of cells in the body, especially the hematopoietic cells. So when MCSF, so macrophage monocyte colony stimulation factor is present, it differentiates into osteoblast precursors. So osteoblast precursors. This is all the osteoblast precursors, which has our rank receptor. So this is a receptor for activated nuclear kappa B. So when it binds to the rank ligand present in the osteoblast, then so it causes its activity, and its activation causes differentiation and resorption of the bone. So low or so osteoblast, osteoproteaserine competitively binds a rank ligand and prevents its binding to rank. So high, so if there is osteoproteaserine is something that binds to rank ligand, which is present in the osteoblast, so it decreases the activity of osteoclast. So if there is high OPZ, so osteoprotein is, if it is high, then high OPZ means rank ligand is less in number, therefore decrease osteoclast activities. But low OPZ means to rank ligand ratio means there is a more osteoclastic activity. Okay, chondrocytes are not involved in the pathogens of pathogens of bone. In the early stages of PDB, pathogens of bone, the adjacent marrow spaces are replaced by highly vascular stromal tissue as a result of increased endothelial cell and fibroblast proliferation due to cytokines separated by osteoclasts. The increased vascularity causes arterial venous shunting that can result in higher heart failure. So in the early stage, the marrow is space replaced by highly vascular stromal cells. In the bone marrow, instead of the marrow cells, there is a high vascularity of stromal cells. Tissues are present. So in this increased endothelial and fibroblast proliferation. So in this high endothelial and fibroblast proliferation, there is cytokine secreted by the osteoclast. This increased vascularity causes AV shunting. So when there is high amount of vascularity inside the bone marrow, then it can result in high output heart failure. Of the patient's biopsy shows character finding osteosclerosis, that osteoblast dominant phase of Peyer's disease. The question especially asking about the initial, that the osteolytic phase of Peyer's disease. So osteolytic phase is the initial stage. So Peyer's disease has osteolytic stage, that is the initial stage of Peyer's disease, where osteoblast activity is predominantly increased. Increased activity and dysregulation of osteoblasts and fibroblasts increase the risk of developing sarcomas in patients. So increased activity and dysregulation of osteoblasts and fibroblasts. So if there is, because there is dysregulation of osteoblasts and fibroblasts, so there is high risk of osteosarcoma in patients with PDB. So now let's talk about thoracic outlet syndrome. Thoracic outlet syndrome. Okay. I think this is a good way, but let's just watch this.
Space between the collarbone and first rib, called the thoracic outlet. This condition can be caused by a variety of factors. May also have weak pulse and stand, but lower blood pressure can be affected. Diagnosis of thoracic outlet syndrome is typically made clinically based on history and physical examination.
Okay, here are all the videos as well, but I don't think I need to watch some more. Let's just study. For Tourette syndrome, so this is a muscle called anterior scalene muscle. So it would be the clavicle, uh, and cervical rib. So the first cervical rib. So this is the first cervical rib, and this is clavicle. These are two bones here. So this is first clavicle, this is there, and there is first cervical rib. So brachial plexus runs above the cervical rib, and posterior scalene, anterior scalene, and middle scalene muscles are present here. So scalene muscle. So scalene muscle are present above the brachial plexus, and cervical artery, sorry, subclavian artery is present here. The patient upper extremity neurological symptoms in the setting of extra rib. So because there is extra rib and upper extremity neurological symptoms, then a highly suggestive of thoracic outlet syndrome. This is because the reason above the first rib and beyond the clavicle, bordered by cervical bones, vertebral bones, and the sternum. Compression of the brachial plexus as it passes through the, there is a compression of the brachial plexus. It passes through the thoracic outlet, can cause upper extremity numbness, tingling, and weakness. Most often in an ulnar distribution due to compression of the lower trunk. Involvement of the subclavian vein and artery can also lead to upper extremity swelling and exertional arm pain. Upper extremity swelling and exertional arm pain can occur because of subclavian vein and artery being involved. So there is a numbness with the brachial plexus running through the thoracic outlet can cause numbness and tension of the weakness, as well as we are mentioning ulnar distribution of the lower trunk. So the lower trunk, due to compression of the lower trunk of the brachial plexus, so ulnar distribution are affected more, and subclavian vein and artery cause swelling and pain. So thoracic outlet syndrome is most commonly due to compression of the brachial plexus in the scalene triangle. So there is a scalene triangle which is formed by the anterior and middle scalene muscles at the first rib. So this is the first rib, anterior and posterior, so anterior and middle scalene muscle. So anterior and middle scalene muscle, anterior scalene muscle and middle scalene muscle, and the first rib. There's a triangle called scalene triangle. So it must be due to the compression of brachial plexus is compressed in that particular triangle. The anterior scalene muscle originates from the C3 to C6 transfer process and attaches to the scalene tubercle of the first rib. So C3 is a scalene muscle. Anterior scalene muscle originates from C3, so cervical 3 to cervical 6 cervical vertebral transfer process and attaches to the scalene tubercle of the first rib. The middle scalene muscle originates from C2 to C7. This one cervical spine, upper and lower, to that of the cervical spine, to that of the origin of anterior scalene, and the transverse process from the transverse of C2 to C7, and it's an insertion of the posterior portion of the first rib. So the first rib has an anterior and posterior portion. So anterior portion is attached to anterior scalene muscle that originates from C3 to C6, while posterior portion attached to C2 to C7 scalene muscle originating from C2 to C7 transverse process and something with the posterior portion of the first rib. The brachial plexus trunk and subclavian artery passes between the anterior and middle scales, and subclavian vein run enter to the anterior scalene. So subclavian vein run. So brachial plexus and subclavian artery run between, and subclavian vein run anterior to the anterior scalene. Okay, the presence of anomalous cervical rib or scalene muscular anomalies can predispose to TOS. Affected patients typically have a history of trauma or repetitive over and arm movements, so swimming, stacking boxes, etc. The coracobrachialis, so coracoid process, and brachialis originates from the coracoid process of the scapula. So scapula has a process of coracoid process, so it originates from coracoid process of the scapula and acts to flex the arm at the glenohumeral joint. So at the glenohumeral joint, it helps in flexion of the arm. So musculocutaneous nerve pierces the muscle near this insertion into the humerus, overage of the coracobrachialis, that excessive bench pressure. So if you bench press more, it can cause entrapment of the musculocutaneous nerve. So bench pressing, so it can cause entrapment of the musculocutaneous nerve, impair elbow flexion. So elbow flexion is impaired, and lateral forearm sensory loss can be present. So musculocutaneous nerve, so in the biceps brachii has two heads, that is long head and short head. So biceps brachii means biceps means two heads. So two heads are long head and short head of the biceps brachii. And musculocutaneous. So this is a coracobrachialis muscle. So musculocutaneous nerve pierces the coracobrachialis. So it pierces the coracobrachialis and forms and runs on the surface of brachialis and biceps brachii. So it's axilla. So axilla has lateral cord of the brachial plexus. So lateral cord of the brachial plexus. So lateral cord of the brachial plexus has a branch that lateral cord of the brachial plexus pierces the coracobrachialis and forms musculocutaneous nerve which runs downwards and supplies brachialis and biceps brachii, biceps brachii, and also forms or continues at the lateral cutaneous nerve of the forearm. So lateral corticobrachial plexus musculocutaneous nerve that pierces the coracobrachialis and comes downwards, form, runs over the brachialis and forms the lateral cutaneous nerve of the forearm. Okay, the subscapularis muscle originates in the subscapular fossa of the scapula. So subscapularis muscle. So there is a muscle called subscapularis muscle originates in the subscapular fossa of the scapula, and it inserts into the lesser tubercle of the humerus. So it inserts in the lesser tubercle of the humerus because it is sub. Sub means less, so lesser tubercle of the humerus. It acts to adduct and interrotate the humerus. So it helps in adducting and interrotating the humerus. Okay, so the teres major muscle and the long head of triceps brachii form the inferior and middle borders of the quadrangular space. So teres major muscle and the long head of the triceps brachii. So teres major is present here. So teres major is present here. So yeah, so draw it here. So teres major is present. This is the teres major and long head of the this is a quadrangular space that we're talking about. So this triangular space is bordered by triceps, long head of the triceps, and teres major. So teres major is here, long head of the triceps, triceps long head is here. So teres major, long of the triceps, and the humerus. And the upper part is teres minor. So teres minor, teres major, long head of the triceps, and the humerus. So teres major muscle and long head of the triceps form the inferior is teres major present inferiorly, and long head of the triceps is present medially, or the quadrangular space through which axillary nerve passes. The intrapersonal axillary nerve within the quadrangular space can cause sensory loss of the lateral soles and impaired solar abduction. So the abduction is impaired. All right. Dupuytren contracture has puckering of the skin. So there is puckering of skin, fibrotic cord, and contracture. So contracture at the metacarpopharyngeal. So there is contracture of metacarpopharyngeal joint. This patient has Dupuytren contracture condition called the progressive fibrosis of the superficial palmar fascia. So fibrosis of superficial palmar fascia. So palmar fascia, the palmar surface, if the fascia undergoes fibrosis, then Dupuytren's contracture can occur. This disease typically involves the fascia at the base of the middle ring and little finger. So middle ring and little finger, the three middle fingers. This typically involves fascia at the base of the middle, middle ring and little finger. So middle and the lateral three fingers, or middle three fingers. Although etiology is unknown, risk factors include age more than 50, male sex, family history, and northern European ancestry. So European ancestry. So in the northern part of the Europe, Dupuytren are very common because it's cold out there, and male sex and female history. So female family history is also very common, and age is more than generally 50. Dupuytren's contracture is thought to be caused by overstimulation of the double signaling pathway. So this is caused by such a molecular detail. It is caused by overstimulation of the double signaling pathway, also regular cellular proliferation. Initial finding of painless fascial thickness. So initial finding include initial finding, double signaling pathway is overstimulated, thereby reducing cellular proliferation, causing fibrosis, and initial finding include painless fascial thickening and puckering of the skin, those proximal to the affected metapharyngeal joints, and as fibrosis continues, pathognomic fascial nodules form along the flexor tendons composed of proliferating fibroblasts and disorder type 3 collagens. So proliferating fibroblasts are present, type 3 collagens are present, disorder type 3 collagen present, the nodules eventually coalesce. So the nodules eventually coalesce into palpable fibrotic cord that tether the fibrous. So the nodules, there are several nodules. So first puckering of this, then nodules are formed because the fascial nodules are formed in the flexors, and fibrotic cords are formed in the flexor tendon of the palmar fascia, leading to loss of finger extension. So contractions occur at the metapharyngeal joint and proximal interphalangeal joint. So MCP and proximal PIP zones. So heterotopic bone formation is in the muscle. So bone formation muscle characteristics of myocytic ossificans. A benign condition that develops after contusion to a large muscle group as quadriceps femoris. Small muscles of the last of the lumbricals. Patients typically report pain in the affected muscles and a palpable lump, heterotopic bone deep in the muscle. So metaplastic bone, which is a metaplasia. So metaplastic bone formation can occur. So there are osteocytes present inside the muscle cells. Linear deposits of calcium hydroxyapatite in the periarticular structure called a painful inflammatory condition called calcific peritendinitis. So if there is calcium hydroxyapatite deposition in the periarticular structures, it causes painful inflammatory condition called calcific peritendinitis. However, it usually affects the rotator cuff. So, however, it usually affects the rotator cuff hand and wrist involvement is uncommon and present with associated inflammatory changes, redness, swelling, and bumps. So in calcific, calcium deposition, peritonitis means around the tendon there is calcium deposition. So as calcium peritonitis is more very common in related of injury, and recent hand movement is uncommon, and with associated inflammatory changes can also be present. So mucinous that can spread in the tendency is characteristic of ganglion cyst. Unlike fibrotic nodes in dependence, contracting ganglion cyst present at large mobile rubbery structures that do not lead to contractions of the hand. Okay, so neutrophilic infiltration of tendon cyst is characteristic of bacterial tenosynovitis. So bacterial tenosynovitis can result in neutrophilic infiltration of cyst because it's an inflammatory condition. It presents with excessive redness, warmth, and swelling, all of which are present in decubitus contracture. Okay, now let's talk about DMARDs, DMARDs. Okay. Let's just watch this video.
The person's immune system mistakenly attacks normal proteins within the body. The resulting chronic inflammation primarily affects the synovium, or lining of the joints, leading to swelling, stiffness, pain, and deformation of the joints. In about 40% of individuals, symptoms may also occur within the skin, lungs, muscles, and cardiovascular system. RA affects about 1 to 1.5% of people within North America and is 3 times more prevalent in women than men. According to CDC, the annual medical costs 1% of the gross domestic anti-inflammatory drugs, $63 billion by 2027. Earlier in the series, we learned about NSAIDs, or non-steroidal mid-joint or DMARDs. These drugs limit the underlying inflammation that causes RA, which not only decreases the pain associated with RA, but also prevents further damage to the joints, preserving their function. DMARDs consist of two different drug modalities, small molecule and biologic. Small molecule drugs are small compounds which bind to and either activate or deactivate a protein of interest. They can be administered and readily absorbed through various routes that we discussed earlier in the series. On the other hand, biologic DMARDs, or BDMARDs, are antibodies, which are protein complexes that are significantly larger than small molecules. While antibodies are normally generated by our immune system to guard us from invading organisms, pharmacologists can hijack this biological response to generate antibodies which target select proteins of interest with incredible specificity. These two modalities differ greatly in their production, cost, administration, and side effects. As proteins, biologic DMARDs must be made using biological processes rather than by the significantly simpler and cheaper chemical processes for small molecules. This also complicates their administration, as large proteins can't be absorbed by normal routes of administration and must be given by injection as often as once a week. Production, storage, and dosing difficulties, 19 and 22,000 RA patients. Therefore, due to dosing difficulties and efficiently relieved side effects are generally lower, demyelinating disease, and associated with uncommon adverse events, including decreased white or red blood cell counts, lymphoma, demyelinating disease, and heart failure. Both of these classes, however, are immunosuppressive and lead to an increased risk for various opportunistic infections by bacterial, fungal, or viral agents that would not cause infection in an individual with normal, uncompromised.
Sorry guys, they did not talk anything about DMARDs, so we need to, I think, look at the slides itself. Slide themselves. So, so this patient has swelling, RA, and morning stiffness in multiple joints for more than 6 weeks. So multiple joint pain, morning stiffness, or swelling and pain considered with rheumatic arthritis. The foundation management is DMARDs, which elevate pain and inflammation and reduce long-term joint restructure and disability. Example of DMARDs are methotrexate, typically first line, sulfasalazine, hydroxychloroquine, minocycline, and tumoric factor biologicals, that is TNF-alpha inhibitors. So, however, the response to DMARD therapy usually takes weeks. That is, so the response to DMARD takes weeks. Therefore, short-term treatment with anti-inflammatory therapies like systemic intra-articular glucocorticoids or NSAIDs can provide rapid temporary relief of symptoms presented patients starting on DMARDs. However, they don't provide adequate long-term control of disease or prevention of joint deformity. Glucocorticoids have the anti-inflammatory effect by inhibiting also phospholipase A2, which decreases prostaglandins and leukotriene synthesis. So glucocorticoids can depress the immune response by inhibiting the transcription of multiple cytokines and adhesion proteins, which reduce leukocyte activation and recruitment. So this is very typical of rheumatoid arthritis. Okay, colchicine is used in the management of both acute and chronic gout. Colchicine works by binding tubulin and inhibiting microtubule polymerization. This results in disruption of neutrophilic chemotaxis, and so neutrophilic chemotaxis and phagocytosis is inhibited. Therefore, inflammatory process response to uric acid crystals is inhibited. Colchicine is not effective in RA. So colchicine is not effective in RA while it is effective in gout. So giant cell arteritis, so I think it had already been discussed before. Giant cell arteritis is systemic fever, fatigue, malaria, waist loneliness can occur, headache can occur, jaw claudication can occur. Okay, jaw claudication can occur. Okay, visual disturbance example ischemic optic neuropathy can occur, and polymyalgia rheumatica is also very common. So polymyalgia rheumatica is very common. ESR, CRP is raised, tumoral artery biopsy can be done, intimal thickening, elastic lamina fragmentation. and multinuclear giant cells are very common. So biopsy, on open biopsy, giant cell can be seen, that is multiple giant cell can be seen, tentacle thickening can be seen, elastic laminar fragmentation can be seen, and glucocorticoid are the mode of treatment. So this patient has a patient with acute painless vision loss and unilateral headache. So acute painless vision loss and unilateral headache. So acute painless vision loss. So there is vision loss, but it is not the word is painless and acute, and unilateral lateral headaches. This pair presentation is most commonly consistent with AION. So anterior ischemic optic neuropathy due to giant cell arteritis. So giant cell arteries can so giant cell arteries can block anterior ischemic optic AION nerve, also called temporal arteritis. So GCA almost occur access in patients age more than 50, and it's carried by granulomatous information of the media with fragmentation of the internal elastic lamina. So internal elastic lamina, there are external internal elastic lamina, internal elastic lamina. So blood vessel has on the in the medials or on the in the very close proximity there is internal elastic lamina, and the outside has external elastic lamina. So there is a granulomatous inflammation of the media with fragmentation of the internal elastic lamina. So fragmentation of internal elastic lamina is common primarily in the arteries of the head and neck. So it is often associated with polymyalgia rheumatica, which presents with achy pain in the proximal skeletal muscle. So there is achy pain in proximal skeletal muscle, that is shoulders and hips. Polymyalgia rheumatica can occur. Okay, so what's present with achy pain in proximal skeletal muscle. So there's pain in proximal part of the skeletal muscles. Ocular manifestations are common in GCA and can lead to irreversible vision loss. AION is due to involvement of the ciliary arteries, and so AION occurs, so neuropathy occurs, anterior ischemic or ischemic optic neuropathy occurs because of involvement of the ciliary arteries and cause a painless, rapidly progressive disease in visual acuity. So painless, rapidly progressive decrease in visual acuity, and GCA can also cause visual symptoms due to central retinal artery occlusion. So central retinal artery occlusion occurs, sector ocular palsies, and infarcts of the visual cortex can occur. So GCA can also cause due to central retinal artery CRA can also be CRAO can occur, extraocular palsies can occur, infarcts to the visual cortex can occur, and transient mononuclear vision loss, that is MRO6 fugax, can also be seen. So the treatment is systemic glucocorticoids, prednisolone, methylprednisolone. However, patients suspected GCA treatment should be started prior to diagnostic testing. So because of the risk of blindness if treatment is delayed. So treatment if delayed can cause blindness, therefore prednisone has to be started before diagnosis. Okay. Acetazolamide is a carbonic anhydrous inhibitor or diuretic used for treating idiopathic intracranial hypertension. So IIP, so idiopathic intracranial IIH, so idiopathic intracranial hypertension. So there is intracranial hypertension because of any idiopathic cause. So acetazolamide decreases the water level, so it decreases the water or CSF pressure. Chronic headache and vision loss primarily in the young, obese woman, and angle postgraph, the eye pain, redness, medial people, and cloudy cornea. So these are conditions with proximal muscle pain. So proximal muscle pain is more indicative of polymyalgia rheumatica or giant cell arteritis. So because it is associated with giant cell arteritis, so giant cell arteritis also has proximal muscle pain. Antibody drug like aspirin, clopidogrel are indicated for patients with MRO6 fugax. So if a patient has MRO6 fugax, we say it's transient mononuclear vision loss. So transient vision loss due to carotid arthritis. So carotid arthritis can occur. However, this patient unilateral headache and proximal muscle. So unilateral headache does not occur. So this atherosclerosis can involve both the vessels, therefore carotid arteries. Therefore, this patient's unilateral headaches and proximal muscle pain makes this a more likely diagnosis. So ganciclovir is used to treat cytomegalovirus retinitis. So ganciclovir is used to treat cytomegalovirus retinitis, which presents with blurred vision, floaters, and photopsia. So cytomegalovirus. So if retinitis occurs because of cytomegalovirus, then blurred vision, floaters, and photopsia can be seen. And flashing lights can be seen. It occurs primarily in patients with significant immune suppression, that is advanced age. So cytomegalovirus virus infection occurs in advanced age. So in advanced age, CMV infection is very common, and ganciclovir is given in a CMV infection. Okay, and in the optic side, there can be vision blurring, floaters, and photopsia can be seen. So much treatment is for the treatment of migraines can cause a variety of ocular symptoms. New onset migraines are uncommon in older individuals, and patient symptoms are more considered with GC and PMR, polymyalgia rheumatica. Okay, so let me talk about lateral knee. So let's see the lateral knee. Here is a suprapatellar bursa. So there is suprapatellar. So this is patella. So this is suprapatellar bursa, and this is subcutaneous prepatellar bursa. This is prepatellar bursa. This is suprapatellar bursa, and this is deep infrapatellar bursa and subcutaneous infrapatellar bursa. So these are bursas present in the knee joint, and this is quadriceps femoris tendon that attaches to the patella. So quadriceps tendon, femoris tendon attached to the patella. All right, and now a bursa. What is bursa? Is a fluid-filled synovial sac. So fluid-filled synovial sac that serves to alleviate pressure and friction at bone joints and ligament attachments throughout the body. But they are vulnerable to injury from acute trauma or chronic repetitive pressure that may also become inflamed due to infection like septic bursitis can occur. Crystalline arthropathy like gout or autoimmune conditions like rheumatoid arthritis. Because bursts are located in prominent and exposed positions, the pain of bursitis may be exquisite and point tenderness is typical. So it's very exquisite and point tenderness is very typical. Other physical bursitis may include swelling and erythema, particularly with more superficial bursa. So swelling and erythema can occur with superficial bursa. Active range of motion is often decreased or painful, but passive motion is usually normal as it results in less pressure on the inflamed bursa. So active motion is painful, but passive motion is normal as it results in less pressure on the inflamed bursa. So because when the motion is acute, so when the motion is acute, then okay. Active mechanism motion is often decreased or painful, but passive is normal because less pressure is kept on the bursa. So now this patient with acute pains, for example, if a patient comes with acute pain and localized tenderness associated with repetitive anterior knee trauma. So repetitive anterior knee trauma occurs from kneeling. Kneeling has typical features of prepatellar bursitis, sometimes called housemaid's knee. So housemaid's knee. So the prepatellar bursa is located in the patella and the overlying skin. So prepatellar bursa is located between the patella and the overlying skin. Other occupations associated with prepatellar and infrapatellar bursa include carpet layers. So carpet layers who have to lay downwards, mechanics and plumbers who have to keep under their knees. So they are prone to prepatellar bursitis. Anserine bursitis presents with pain along the medial knee and well-defined tenderness approximately 4 centimeters distal to the anteromedial joint margin of the knee. So anserine bursitis can occur. So anserine bursitis is the anserine region presents with pain along the medial knee and well-defined tenderness approximately 4 centimeters distal to the anteromedial knee. So anteromedial knee joint margin of the knee. It frequently results from obesity or obesity in athletes. So where is anserine bursa? So anserine bursa is here. So this is pes anserinus. So pes anserinus represents 3 different tendons. So SGS tendon, semitendinous. So semitendinous, half tendon like structure, semitendinous tendon. Or the other tendon is gracilis tendon. So the other tendon is gracilis tendon, and then sartorius tendon. So pes anserinus represents sartorius tendon, semitendinous tendon, and gracilis tendon. So gracilis SGS, gracilis tendon, and semitendinous tendon. So these represent pes anserinus, and below or behind it there is anserine bursa, and just inside the anserine bursa there is medial collateral ligament. So medial collateral ligament is present inside the anserine bursa. Okay. Okay, these are muscles. Sartorius muscle is here. Gracilis muscle, semitendinous muscle is here, and semimembranous muscle is also here. So anserine bursa is present with pain along the medial knee and well-defined tendon is approximately 4 centimeters distal to the anterior medial joint. So in the anterior medial joint margin of the knee, 4 centimeters distal to the anterior medial margin, there is anserine bursitis. Okay. Popliteal or Baker's cyst are caused by swelling of the gastrocnemius or semimembranous bursa. So gastrocnemius G or semimembranous bursa. Gastrocnemius muscle or which is present posteriorly or semimembranous bursa can be swollen, which leads to popliteal cyst. They often form due to extrusion of synovial fluid from the knee joint into the bursa. So extrusion of synovial fluid from the knee joint into the bursa in patients with osteoarthritis or inflammatory joint disease. So they often form due to extrusion of synovial fluid. So synovial fluid goes out from the knee joint into the bursa of the patient with osteoarthritis or inflammatory joint diseases. The suprapatellar bursa is located anteriorly between the distal femur and quadriceps. So between the distal femur, and the quadriceps muscle, there's a bursa which is suprapatellar bursa. Bursitis here is most often caused by direct blow to the distal thigh or prolonged repetitive quadriceps activity like running. So bursitis can occur because of repetitive activity like running. All right. Okay. Bursitis is the most common cause by direct blow to the distal thigh or prolonged repetitive quadriceps activity. For example, running. So gouty arthritis. Let's talk about gout, which involves first metatarsopharyngeal joint or knee swelling or edema. So tenderness can occur. Symptoms are rapid over 24 hours. So as shows needle-shaped, negatively birefringent crystals. So gout has negatively birefringent crystals. NSAIDs can be given naproxen and indomethacin can be given if no other contraindications, while colchicine can also be given as a second line therapy. Synovial fluid analysis in this patient with occurred monoarthritis shows needle shaped. So there are needle shaped negative birefringent crystals. So birefringent crystals, that is monosodium urate crystal under polarized light, which are diagnostic for gout. Phagocytosis of urate crystals by neutrophils. So urate crystals are phagocytes by phagosed by neutrophils causes and which causes release of various cytokines and inflammatory mediators that lead to further neutrophil activation and chemotaxis. So okay, so the neutrophils eat it and release cytokines, which leads to other or further neutrophil activation or chemotaxis can occur. So you're doing a feedback loop that amplifies the inflammatory process. So therefore, there is severe inflammation. So this is MSO crystal with compensated polarized light. So polarized light, MSO crystals look like this. Means axis of slow vibration. So in the axis of slow vibration, these are seen. So NSAIDs are for treatment for most patients. The cycloxanase enzyme and therefore decrease prostaglandin synthesis and exert a broad anti-inflammatory effect that gives inhibition of neutrophils. So okay, so NSAIDs should be avoided in patients with renal and hepatic dysfunction. For those patients with renal or hepatic dysfunction, NSAIDs are not indicated. Lipoxygenase inhibitors like xylotone decrease production of proliferative leukotrienes, especially in asthma. So lipoxygenase inhibitors are not used for the treatment of gout. So glucocorticoid is systemic or intraarticular is used in patients with contraindications to both NSAIDs and colchicine, like renal dysfunction, elderly, etc. In addition, this patient has diabetic mellitus and glucocorticoid increases blood sugar levels. All right, buddies. Antibiotics are used in patients with acute septic arthritis and analysis with some bacteria, high concentration of leukocytes. So, septic arthritis will solve bacteria. So, these small things are bacteria. So, these small things are bacteria, and these are neutrophils. Right. So, TNF inhibitors like infliximab, etanercept are used as DMARDs in rheumatic arthritis. So, infliximab, TNF inhibitors, and TNF means T looks like I. So, infliximab, etanercept, they are DMARDs used in RA. Now, similarly, uric acid lowering agents are with uric acid, uric acid like probenecid. So probenecid helps in excretion of uric acid or xanthine oxidase like allopurinol. Febuxostat is used to prevent acute attacks in patients with recurrent or progressive gouty arthritis and those with macroscopic tophi. So they can be used to prevent acute attacks in patients with recurrent so in recurrent patients, febuxostat or allopurinol can be used like they are xanthine oxidase inhibitor, while some drugs like probenecid are uricosuric agents. Okay, with recurrent to progressive gouty arthritis and those with macroscopic tophi, these should not be initiated during acute gout attack as they can exacerbate acute arthritis. So they can exacerbate acute arthritis, therefore they are not used during the gout attack itself. So this is also maybe gout. Now let's talk again about ankle spondylitis. It is chronic. It is a chronic insidious back pain and buttock pain. It causes insidious back and buttock pain. Worse onset is in adults. Worse with arrest and relieved with activity and warm showers. In terms of finding include decreased spine range of motion and expansion, stiff or stooped posture, tenderness in spine, acetabular joint, and peripheral tendon arthritis. Insertions like Achilles tendon can be, painful. Dactylitis, swelling of fingers and toes can occur. Uveitis can occur. Increased osteoclast activity and bone erosions can occur. And increased bone or syndesmophyte formation can also occur. Elevated ESR, CRP, and SLB27 can be positive. This patient presenting with chronic back pain. So if they're a patient with chronic back and buttock pain, so back pain as well as buttock pain associated with stiffness. So stiffness means ankle spondylitis. The symptoms are characteristically worse in the morning and improve with stretching and warm showers. So improve with stretching and warm showers. Yes, it's more common, most common in men aged less than 50, and turn markers here are usually elevated. And yes, it's characterized by simultaneous erosion of bone and newborn formation. So there's erosion of bone as well as newborn formation. Unlike RA, where only erosions are seen, insult pathogens is driven in part by inflammatory cytokines like TNF alpha, interleukin 17, which causes activation of osteoclast precursor cells and bone neurons. So osteoclast activation occurs because of TNF alpha, interleukin 17. In ankylosing spondylitis, they occur primarily in the vertebral bodies and as destruction of the microstructure, architecture, increasing the risk of secondary osteoporosis and compression fractures. Once this inflammation subsides, the repetitive process leads to excessive new bone formation, especially in areas where fat metaplasia fills previously eroded sites. Okay, once the inflammation subsides, the reparative process leads to excessive new formation. So after the inflammation subsides, there is excessive formation of new bone, especially in areas where fat metaplasia fills previously eroded sites. So especially the bone formation occurs in those areas where was deposited in the previously eroded sites. In contrast to erosions, bone formation occurs primarily at the periosteum cartilage junction. So periosteum means a periosteum cartilage junction and manifests as breathing signs and dysmorphize in the vertebral column. So the bone formation occurs in the cartilage to periosteal junction. So and manifest dysmorphies are formed. This leads to spinal rigidity, postural alterations, and increased risk of fracture. Alright guys, so bamboo spine can be seen. This is bamboo spine. Alright, yes. Okay, fuse syndesmophytes. These are syndesmophytes, they are lateral projections and they are fused here. Fusion and destruction of the sacral leg joint. So there is no sacral leg joint here and here. So this is fused. So fibrous dysplasia is a benign tumor. So fibrous dysplasia is a benign tumor, bone tumor characterized by focal bone dysplasia with spindle cells. So fibrous dysplasia has spindle cells. Fibrous means fiber-like, so spindle cells are present in fibrous dysplasia, and so it typically presents as asymptomatic lytic lesions. Fibrous dysplasia is an asymptomatic lytic lesion. So just like multiple myeloma. Lytic lesions can be seen most commonly in the femur and tibia, and fibrous dysplasia are usually seen in children and is not an inflammatory condition. Like that is normal ESR is present. So it is an inflammatory condition, it's not an inflammatory condition, rather it's just a deposition of fibrous spindle cells. Okay, so this is a focal bone dysplasia, and usually seen in children. So they are seen in fibrous dysplasia. Fibrous tissues are present in children, so dysplasia is in children, not an inflammatory condition. So non ESR is present. So previous is a bone is characterized by excessive and decent bone formation with focal thickening of trabecular and cortical bones. Trabecular and cortical bone thickening occurs. Features include bone pain, fractures, and arthritis of adolescent joints. However, it's uncommon at the age less than 50, and patients with back pain is more much over the years. Intervertebral disc protrusion and thickening of ligamental flava can lead to spinal stenosis. So if there is protrusion of the central disc or vertebral disc, protrusion occurs or thickening of the ligamental flava, they can lead to compression of spinal cord, leading to spinal stenosis. The pain is in this disorder typically relates to the posterior thigh, so posterior thigh pain can occur in legs and related by sitting and flexion of the spine, not actively. So the pain subsides during while sitting. So spinal stenosis is usually seen at age more than 16 years. It's normal. So stenosis is at age 60 and is normal. So multimodal is characterized by plasmacytic infiltration in the bone marrow. Patients often back pain at night. So at night and during rest, but stiffness is less prominent. So there is no stiffness. So stiffness in a young healthy adult links towards or hints towards ankylosing spondylitis, and is uncommon before age 50. All right, buddies. So now spondylolisthesis. So now let's talk about spondylolisthesis. I think this will do. Let's talk about spondylolisthesis lecture. Okay. Here the videos are very long. Let's watch a very short video, or let's just search. Okay. I don't need to watch this video.
We'll be in this video, let us look at this topic, spondylolisthesis. So look at this image here. The normal spine, okay, will have this Scottish dog base, but without column, okay, the gateway of the vertebrae plate. Here in this spondylolisthesis, it has all kind of thing that was spread. Okay, so there is 90 definitely fracture. Also, also that intra-articularis. Intra-articularis
Okay, so spondylolisthesis means this lived forward slip is about five vertebrae. So the upper vertebra slips over the lower one. So spondylolisthesis fracture of the pars integralaris can occur. So pars integralaris fracture can occur, mostly so separate or forward movement of the vertebra. So this is, and it causes spinal or pinch L5 spinal nerve as well. That this adolescent athlete has spondylolisthesis. That is, adolescence has generally isthmic type of spondylolisthesis. So spondylolisthesis and displacement of the vertebral body, which often occurs due to bilateral spondylolysis. So it's often occurs due to bilateral spondylolysis. So it means pars integralaris fracture. So after pars integralaris fractures, then anterior part becomes hollow or loose. So it moves anteriorly, slipping over the lower vertebra. This vertebral column is formed by stacked vertebrae. So the vertebral column is formed by stacked vertebrae separated by cartilage in the disc, held by thick ligaments. The vertebral body is from the anterior weight-bearing portion of the vertebral column. So vertebral body is now vertebral body is from the anterior weight-bearing portion of the vertebral column. The posterior portion of the vertebral column is midline, spinous process, the transverse process, and articular process of the facet joint. So in the the anteriorly the vertebral present which bear weight. Posteriorly there are midline spinous process. So there are midline spinous process together with transverse process. So the spinous process, transverse process, and inarticulating processes, upper and lower articulating process of the facet joint. From the posterior vertebral arch, so posterior vertebral arch connects the anterior and posterior portion of the vertebral column. The posterior vertebral arch connect anterior and posterior portion of the vertebral column and consists of the pedicle, intervening parts, integrocularis, and the lamina. So the posterior vertebral arch contains pedicles. So contains pedicle, intervening past interarticularis, and the lamina. The posterior vertebral arch and the posterior portion of the vertebral body form the triangular shaped spinal canal. The posterior vertebral arch and the posterior portion of the vertebral body. So and each vertebra has an anterior joint between the vertebral bodies separated by disc and a pair of facet joints posteriorly. Forward flexion of the spine stresses the anterior portion of the spine. So, forward flexion of the spine stress produces or puts on stress in the anterior portion of the spine linked to the vertebral body and disc. A repetitive extension of the spine as a gymnast stretches the facet joint. So it stretches the facet joints in the posterior vertebral arch, which leads to spondylolysis with subsequent spondylolysis. So especially in athletes, spondylolysis is very common. Cervical vertebral anatomy. So this is body. So this is the body of the vertebra. There is the spinous process of the vertebra, and there are transverse. So there are transverse processes with transverse foramen through which vertebral artery can run upwards, and this is the lamina. So this is the facet joints. So facet joints are on the side, and joining the facet joints and the spinous process are facet joints and the spinal process and the vertebra, spinous process of the vertebra. They are lamina. So lamina into infraarticular process, the supraarticular process also present. The intervertebral disc is the soft absorbing cartilage structure between the vertebral bodies made of top cartilage ring, that is annulus fibrosus, surrounding a soft cartilaginous core, that is nucleus pulposus, is present in the center, while in the periphery that is around it, there is annulus fibrosus. Okay, fibrosus. And the car sock absorbing cartilage structure between the anesthesis and fibrocartilage score, that is nucleus pulposus. Damage can lead to herniation. So herniation can occur because of damage of the disc or loss of space between the vertebral bodies, but not cause anterior displacement of the vertebral body. So it will never cause anterior displacement of the vertebral bodies. Spinous process spinous process projects posteriorly in the midline and serves as an attachment to the muscles and ligaments. The paired transverse process project posterolaterally from the vertebral arch. In thoracic vertebra, faces on the transverse process artery with the tubercles of the ribs. So faces in the thoracic vertebra, in the thorax especially, where ribs can attach, there are tubercles in the tubercles. There are facets where tubercles of the ribs can attach. Fractures of the spinous process or transverse process are considered stable. So if there is fracture of spinous process or a fracture of transverse process, then they are considered stable, but they are typically result in either neurological compromise or displacement of the vertebral bodies. However, passage joints, if compromised, can result in spondylolysis or as such. So vertebral body is weight bearing. So vertebral body weight bearing anterior portion of the vertebra. Fracture of this area causes avulsions or commercial fracture that lead to loss of height, but not typically due to displacements. Okay. Now Trendelenburg gate. Trendelenburg gate. This is search about Trendelenburg gate. Okay. Okay, I think this will do.
Trendelenburg gait. During the stance phase of the gait cycle, the gluteus medius works to maintain both hips at the same level. What is Trendelenburg gait? Trendelenburg gait is an abnormal gait that is usually found in people with weak abductor muscles of the hip, which is supplied by the superior gluteal nerve. Here you can see a patient example of Trendelenburg gait. The patient could not abduct the right hip due to weakness of the abductor muscles on the right side. If the patient has weakness on one side of the pelvis, and when the patient stands on that side, the pelvis on the contralateral side will drop. This is called the Trendelenburg sign. The gluteus medius is very important during the stance phase of the gait cycle in order to maintain both hips at the same level. The stance phase accounts for about 60% of the gait cycle. 3 times the body weight is transmitted to the hip joint. The hip abductor actions account for 2/3 of the body weight. When identified the weakness stance phase, the pelvis drops to the opposite side. Here you can see an example of weakness of the abductor muscle, as well as avulsion of the abductor muscle tendon. Weakness can also occur in patients with L5 radiculopathy or avulsion of the abductor muscle tendon, which occurs with decreasing frequency after hip replacement surgery. The superior gluteal nerve injury is a major factor in this gait. The positive Trendelenburg sign occurs when there is dysfunction of the abductor muscles and the body is unable to maintain the center of gravity on the side of the stance leg. The patient will show an excessive lateral lean to keep the center of gravity over the stance leg. Here you can see an example of a normal gait, the Trendelenburg gait, and the compensating Trendelenburg gait. With bilateral weakness of the abductor muscles, the patient will have dropping of the pelvis on both sides during walking, which leads to water-weight motion. This can be seen in patients with myopathies.
Makes sense. So superior nerve injury can cause Trendelenburg sign or Trendelenburg gate. So proper placement spares nerves. Trendelenburg sign, hip drop, observe contralaterally, weakened gluteus minimus cannot contract. So if there's weakness of right-sided gluteus medius muscle, then it cannot carry the left-sided legs during when the legs are brought upwards. So this is how Trendelenburg gait occurs. Okay. All right, buddies, and so yeah, the patient is exhibiting classic renal gait, that is gluteus medius gait, which is characterized by hip drop on the contracted unaffected side. So when that foot is raised, this gait is observed when there is injury to the superior gluteal nerve or to the gluteus medius muscle. The superior gluteal nerve is derived from the L4S1 ventral rami and leaves the pelvic through the gluteosidic foramen above the level of piriformis. So above the level of piriformis, gluteosidic nerve runs through the gluteosidic foramen. So okay, so it's going to from L4 S1, so L4 to S1, L4 L5 S1, so L4 L5 and S1 ventral rami and lifts the pelvis through the superior gluteal process, so the gluteosidic foramen above the level of piriformis. In this, the superior medial quadrant of the buttocks have a high probability of injury in the superior gluteal nerve. So if there is superior medial quadrant of the buttocks, so if any index is given the superior medial quadrant of the buttocks, so superior medial quadrant, so superior and medial quadrant of the buttocks, like in here, then there is high probability of injury in the superior gluteal nerve. In large size sciatic nerve is a risk of injury following an injection in any quadrant of the buttocks. So sciatic nerve can be injured while giving an injection in the buttocks or the superposition of the posterior thigh. So in the, or in the superposition of the posterior thigh. However, sciatic nerve injures the knee flexors, that is hamstrings. So knee flexors, that is hamstrings, and leg foot muscle injury to the nerve will cause weakness in knee flexion and ankle plantar flexion. So ankle plantar flexion. So plantar flexion would drop rather than trend longer gait. So if there is sciatic nerve injury, then flexion will be of impaired. So flexion of the knee will be impaired as well as the plantar flexion of the foot will be seen. So foot drop will be seen. Superlateral quadrant of the body is considered the safest place for dorsal gluteal injections. However, damage to the gluteal and sciatic nerve can still result from this region. Most intragluteal injections will target the anterolateral gluteal area, that is von Hochstetter triangle. So most of the nations would only target anterolateral, so anterior and lateral gluteal area, which is called von Hochstetter triangle. So von Hochstetter triangle to minimize the possibility of nerve damage. Von Hochstetter, okay, ventrogluteus in the side, so it is bounded by, so there is ASIS, means anterior superior iliac spine, so there is anterior superior iliac spine on the upwards part, palm on the greater trochanter, so palm is on the greater trochanter and palm on the greater trochanter, and the triangle formed by the index and middle finger with the anterior, the upper border by anterior superior iliac spine is the von Hochstetter triangle. So von Hochstetter triangle is a safest area for injections. Okay, synovitis. Okay, this patient has acute joint pain. Acute joint pain. So there is acute joint pain, swelling, and erythema with restricted range of motion. This includes acute joint pain, swelling, erythema, means it can be septic arthritis as well. Okay, it's considerable synovitis. Acute undiagnosed synovitis, especially when accompanied by fever. So acute undiagnosed synovitis. So acute undiagnosed synovitis. So if synovitis is not diagnosed, especially when accompanied by fever or leukocytosis, so synovitis is not diagnosed, especially when accompanied by fever or leukocytosis, represents a true emergency and warrants expedited evaluation. Potential causes include septic arthritis by gonococcus or non-gonococcus, gonococcus or non-gonococcus, crystal arthropathy like gout, hemarthrosis, or rheumatic disease. Delayed diagnosis of septic may lead to loss of joint or long-term disability and may be fatal as well. Acute synovitis is best evaluated using with diagnostic arthrocentesis. So acute synovitis is evaluated with diagnostic arthrocentesis and synovial fluid analysis. Gross inspection may assist diagnosis with purulent or cloudy fluid, suggesting an infectious or inflammatory process. Fluids will be sent for crystal analysis, cell count, stem culture, blood culture also be drawn if septic arthritis is suspected. Okay, MRI is useful to evaluate menisci ligaments around the soft tissue around the joint. However, it is time consuming and will not provide definite diagnosis of septic arthritis. Rare nuclear bone scan are useful in evaluation of metastatic or infectious bone disorders. However, the findings are sensitive but very non-specific for the potential cause of synovitis. And synovial fluid crystal analysis is different for gout. Serum uric acid levels are usually less useful for diagnosis and may be normal during acute gout attack. In addition, serum uric acid levels do not rule out of the important cause of synovitis such as septic arthritis. Okay, so medicines associated with gout, so reduce uric acid excretion by uric drugs like diuretics like hydrochlorothiazide. So hydrochlorothiazide and gout can be used. So hydrochlorothiazide and gout can be used, which help in excluding the amount of uric acid in the urine. So diuretics can be used like hydrochlorothiazide and furosemide. So hydrochlorothiazide and furosemide can be used. Salicylates like low-dose aspirin can be used. So salicylates like low-dose aspirin. So low-dose aspirin can also be used. ACE inhibitors like lisinopril can be used. Cyclosporin can be used. Cyclosporin can be used. So reduced uric acid excretion, so increased uric acid production. So medication associated with surgery. These are the drugs which cause uric acid levels to rise in blood. So uric acid level can rise in blood because of less uric acid excretion, because diuretics like hydrochlorothiazide and furosemide, all of them, please wait. Okay, this was the same video. All right, so uric acid excretion can, is decreased because of taking diuretics like hydrochlorothiazide, furosemide, salicylates like low-dose aspirin, ACE inhibitors like lisinopril and cyclosporine can also cause uric acid increment uric acids, or any uric acid can be increased by taking cytotoxic drugs like tumulizis, which causes tumulizis syndrome. Okay, ACE inhibitors increase uric acid. Number one, diuretics increases uric acid like thiazide or hydrochlorothiazide or furosemide. Salicylates can increase because it is itself is a very acidic compound, so it can lead to increase in uric acid level in the body. Similarly, ACE inhibitors like lisinopril can be used, and the fourth is cyclosporine. So yeah, cyclosporine can also be used. So these are four drugs, and increased uric acid production is caused by chemotherapy. A rapid decline in uric acid level can be caused by uric acid drug like probenecid or allopurinol. This patient has the patient with acute monoarticular arthritis of the knee with synovial fluid evidence of inflammation, needle shaped monosodium urate. Crystal means gout, and gout develops in patients with hyperuricemia and is associated with severe risk factors including excess alcohol intake, meat or seafood consumption, chronic kidney disease, and certain medication. Cyclosporine is a common cause of gout patients in patients who have undergone solid organ transplant. So after solid organ transplantation, then there are for immunosuppression, cyclosporine is generally given. So particular renal transplantation. So this medication impairs certain excretion of uric acid, resulting in hyperuricemia. So this patient is excreted instead of uric acid, therefore hyperuricemia occurs in the blood. Although high-dose systemic glucocorticoids can be used to treat acute gout, the low dose used for immunosuppression in patients who have undergone transplantation are not sufficient to prevent gout flares. So these are crystals of gout. So okay, increased production of uric acid is commonly due to purine-rich diet. So increased production of uric acid due to purine-rich diet like red meat, seafood, excessive alcohol intake, fructose sweetened beverage intake, or disorders associated with increased cell turnover like mitoprolific disorders, cancers, etc. So uric acid production is increased due to purine diet like red meat, or shellfish, or seafood, or excessive alcohol intake, fructose sweetened beverage intake. So there is taking like some sweetening, some beverages like with high sugar like Coca-Cola and others can cause it. Disorders associated with increased cell turnover like mitoprolific disorders or cancers can also lead to uric acid increment. Urate lowering agent like allopurinol used to prevent recurrent gout but can occasionally precipitate gout due to rapid decline in blood uric levels. So if there's a decrease in blood uric acid level, then to hide uric acid will deposit in which can disrupt pre-existing crystal deposits and increase their immunogenicity. So now since the uric acid levels are acutely decreased, now the immune system will misconfuse or confuse the existing uric acid present in uric acid, and will therefore our body confuses and it increases their immunity. This person not taking a medication that lowers uric acid level. So patients who have malignant ancestry with high tumor burden, so like acute lymphoblastic leukemia, can develop tumor lysis syndrome due to when cytotoxic chemotherapy is initiated. So cytotoxic chemotherapy increases uric acid levels because they rupture or causes tumor lysis, especially with cases like ALL or massive release of nucleic acid into the circulation from lyse cells into the serum uric acid level due to catabolism of purine nucleic acid and can precipitate gout. Diuretics like furosemide, hydrochlorothiazide can be associated with gout, and this medication can reduce uric acid excretion in the proximal tubule and also cause volume depletion leading to decreased renal perfusion and filtration of uric acid. This patient has normal serum creatinine level and renal function, so adequate renal function is there. The reactive arthritis. Okay, reactive arthritis. Okay, so preceding infection like genitourinary infection or enteritis or gastric infection. So genitourinary infection like by chlamydia and gastric enteric infection by salmonella, Shigella, Yersinia, campylobacter, clostridioides difficile can cause reactive arthritis. So in musculoskeletal, so in musculoskeletal system, it causes asymmetric oligoarthritis. So reactive arthritis means conjunctivitis and STD like symptoms are like burning, maturation, and asymmetric oligoarthritis can occur. Okay, extraordinary symptoms like conjunctivitis, uveitis, urethritis. So urethritis can occur, such as prostatitis can also occur. Normal keratoderma, blenuragicum, circulated balanitis can occur. This a patient with young man with acute lower extremity arthritis and sterile joint. So if there is a sterile joint diffusion following a GI infection, has typical symptoms of reactive arthritis. Reactive arthritis is spondyloarthropathy that preferentially affects SLB P27 positive individuals. It typically presents as an asymmetric arthritis of the lower joint. Common symptoms include urethritis and keratoderma. Keratoderma is so thickening of the skin, and blenuragicum can also occur. Reactive arthritis is most common following infection with Campylobacter, Shigella, Salmonella, those cause dysentery. Campylobacter, Yersinia, Chlamydia, and Bartonella can also occur. Also cause it. The clinical manifestations are caused by immune complexes involving bacterial antigens. However, it does not represent dysentery infection and zone aspirate. So it's a reactive, not infectious arthritis. It's a reactive arthritis, but not infectious. C1 inhibitor deficiency with hereditary angioedema. So C1 esterase inhibitor deficiencies. If there is deficiency in C1 esterase, so C1 will not be broken down, therefore it causes hereditary angioedema. C1 inhibitor degrades C1 and prevents excessive complement activation inflammation, but because of lack of absence of this enzyme or absence of this enzyme, so there is high amount of C1 which activates complement system, and inflammation triggers inflammation. So high titer of ASO antibody, so anti-streptolysin and O antibody are seen in non-purulent complications of group A streptococcus infections such as rheumatic fever and glomerulonephritis. So high titer of anti-streptolysin O antibody are seen in non-purulent complications of group A streptococcus infection like rheumatic fever and glomerulonephritis. Antinuclear antibody and rheumatic factor are non-specific markers of autoimmune disease, primarily SLE and SRA respectively. So antinuclear ENA and rheumatic factors are more specific for SLE and RA. So the rheumatic factor is more specific for RA. These conditions are less common in men and do not usually present with acute monoarthritis and are not associated with recent diarrheal illness. So if there is diarrhea, then okay. So there is a very well-known sign called Gowers and proximal muscular dystrophy is a term that applies to various diseases that manifest with progressive muscle weakness. So it refers to diseases that manifest with progressive muscle weakness. Deletions of the dystrophin gene, so deletion of the gene, or frame set mutation of the gene, or partial frame mutation of the gene that codes for a dystrophin protein on that chromosome X. Part 21 are the most common mutations inducing muscular dystrophy and Becker muscular dystrophy. Deletions are not a multiple of 3 changes in reading frame, causing a frame set that are not a multiple of 3 cause frame set mutation, which results in non-functional protein and severe clinical manifestations like in DMD, while partial deletions like in contrast, deletions that are multiple of 3 base pairs preserve the reading frame, resulting in truncated but functional protein and milder clinical phenotype like in Baker's muscular dystrophy. Dystrophin is a structural component of skeletal muscle fiber that provides mechanical stability to the sarcolemma. It links a component of cytoskeleton that is actin. So it links component of cytoskeleton that is actin to transmembrane protein alpha and beta dystrophy glycans. So dystrophic glycans. So it links a component of cytoskeleton. So it links actin to transmembrane protein, which is called alpha and beta dystrophic glycans. So alpha and so transmembrane protein like dystrophic glycans and actin are linked by dystrophin. Okay, they are connected to the extracellular matrix. Loss of dystrophin results in cellular injury with myonecrosis. On like microsome, there is segmental regions of the myofibers. So there is segmental degeneration and regeneration of the myofibers with marked variation in size. So with marked variation in size, both atrophic and hypertrophic fibers. Over time, the muscle tissues undergo progressive fatty replacement. So over time, the muscle tissue undergoes progressive fatty replacement. So there's pseudo hypertrophy. So pseudo hypertrophy occurs. On clinical examination, Gowers sign and calf enlargement of boy age 2 to 5 is classic for DMT. Calf hypertrophy allows affected children to overcome proximal muscle weakness, but it's later replaced by fat and connective tissue causing or pseudo hypertrophy. The Gowers involves the use of one's hand to rise from a squat or from a chair to compensate proximal muscle weakness. In myzel, inflammatory infiltration is found in muscle biopsy of polymyositis. So in polymyositis, there is endomysial inflammation infiltrate. So muscle biopsy is done, and there it can show the inflammation or inflammatory infiltration in the endomysium. Dermatomyositis is associated with perifascicular inflammation. So endomysial inflammation is seen in polymyositis, while perifascicular inflammation, around the fascicles inflammation can be seen in dermatomyositis. Both diseases cause proximal muscle weakness, but not distal muscle hypertrophy. So both diseases can cause proximal muscle weakness, but distal muscle hypertrophy is not common. Endoneural inflammation, so inflammatory infiltration. So endoneurial, so inside the neurons, if inflammatory infiltration seen is characterized as GBS, which classically manifests as ascending flaccid paralysis and hyperreflexia. So endoneural inflammatory infiltration characteristic of Guillain-Barré syndrome, which classically manifests as ascending so we have GBS. So inside the neurons, if there is inflammation, then the GBS is more suggestive. So there is ascending flaccid paralysis, and there can be ascending flaccid paralysis and hyperreflexia. Examples of ion channel myopathies include hyper and hypokalemic periodic paralysis. So ion channel myopathies include hyper and hypokalemic periodic paralysis, which presents with episodic painless muscle weakness. Okay, painless muscle weakness occurs without pain in channelopathy. So channelopathic myopathies, hyper and hypokalemic periodic paralysis. Okay, Charcot-Marie-Tooth disease. Charcot-Marie-Tooth disease is due to mutation of genes responsible for myelin synthesis. So if the synthesis of myelin is defective because of mutation of the genes, then can cause Charcot-Marie-Tooth disease. Affected patients frequently present with digital muscle weakness. So Charcot-Marie-Tooth disease. So Charcot-Marie-Tooth disease. Affected patient present with digital muscle weakness occurs sensory loss, atrophy of the calf muscle producing characteristics stroke leg deformity. Stroke leg deformity can be seen. Mutation involving sarcomere proteins are responsible for hypertrophic cardiomyopathy. So mutation involving sarcomere proteins, so sarcomere proteins if mutated can cause hypertrophic cardiomyopathy and sort of familial dilated cardiomyopathy. So familial dilated cardiomyopathy or hypertrophic cardiomyopathy can occur if mutations are involving sarcomere proteins. So there is additional muscle weakness, sensory loss, and atrophy of calf muscles. Okay. So giant cell arteries have been discussed multiple times. Okay, so giant cell arteritis, so systemic signs like fever, fatigue, malaise, weight loss, headache, claudication, visual instruments like ischemic optic neuropathy, and polymyalgia rheumatica. Elevated ESR and CRP protein can occur, temporal biopsy, so intimal thickening, elastic laminar fragmentation, and multinuclear giant cell. So multinuclear giant cell can occur, and elastic laminar fragmentation can also occur. Glucocorticoids are treatment. So patient with headache and jaw claudication has typical symptoms of giant cell or temporal arteritis. GC occurs almost excessively in individuals age more than 50, and it's characterized by granulomatous inflammation of the media with fragmentation of the internal elastic lamina. So there is fragmentation of internal elastic lamina, particularly in the head, arteries of the head and neck. About half of the patients with GCA have polymyalgia rheumatica, which presents with pain and stiffness of the shoulders and hips. So inflammatory markers like ESR, CRP have a high sensitivity to GCA but non-specific. The temporal artery biopsy can be done. Okay. This can cause severe ischemic optic neuropathy due to ophthalmic artery occlusion. So ophthalmic artery can be occluded, which can lead to blindness if not treated promptly. Other optic complications of GC include amaurosis, fluid gags, central branch CRAO, cerebral infarction leading to central visual field defects. GC is therefore considered a medical emergency, and physicians should not wait for biopsy before starting glucocorticoid. So GCA has to be given glucocorticoid. Prednisolone, methylprednisolone very acutely. Acute angle closure glaucoma causes vision loss of ocular pain, headache and nausea. Examination findings include conjunctival erythemas, conjunctival becomes red, corneal opacity can occur, and fixed mid-dilated pupils can also be seen. Acute angle closure glaucoma. So risk factor include farsightedness, so hyperopia. So hyperopia means um, myopia means nearsightedness means the bigger eyeball, while hyperopia means smaller eyeball. So farsightedness can cause acute glaucoma. Anticholinergic drugs can lead it, or anticholinergic drugs means or adrenergic agonist drugs. So these two can also cause acute angle closure glaucoma. Proliferative retinopathy like neovascular retina is most commonly due to long-standing ongoing diabetes. Although treatment of GCA with systemic glucocorticoid can raise blood glucose, untreated GCA does not cause proliferative retinopathy. So untreated GCA does not cause proliferative retinopathy. Retinal detachment presents with floaters, flashing of lights, photopsia, and progressive monocular vision loss. Risk factor for retinal detachment just include prior eye trauma or surgery, nearsightedness, and myopia, age-related macular degeneration. So age-related macular degeneration can occur, and diabetic retinopathy can also occur. RVO, so the retinal vein occlusion or presence with painless blurring of vision in a limited visual field. So branch retinal vein occlusion or entire eye central retinal vein occlusion. So there can be blurring of vision in particular fields. So if there is only vision loss in a particular field, there is branched retinal vein occlusion. If the entire eye is see blurring or a painless blurring of vision is seen, Then it can be simple RDO, major risk factor includes diabetes, hypertension, atherosclerotic disease, glaucoma, smoke, or obesity. Vitreous hemorrhage. So vitreous hemorrhage causes variable severity, monocular vision loss. So monocular vision loss can occur in vitreous hemorrhage. So monocular, only one eye can be affected. Examination shows a loss of red reflex. So loss of red reflex is seen, and obscuration of the retina can be seen. So major cause into ocular injury, anticoagulation, or diabetic retinopathy, or intraocular tumor. So they can cause it. All right, buddies. Okay, let's talk about osteoarthritis and rheumatoid arthritis. So, osteoarthritis occurs increased age, people equal to 60, often younger in rheumatoid arthritis. Knees, hip, DIP joint is most commonly involved, but DIP is spared here. But MCP joint, PIP joint, and wrist are most commonly affected. Morning stress is none, or it is prolonged. Symptoms are absent, symptoms are present. Hard bone and adult joints, soft, spongy, warm joints are present, especially in rheumatoid arthritis. The patient with older woman with huge dependent joint pain as typical features of osteoarthritis. So older woman means osteoarthritis. Patient with OA also have osteoporotic formation leading to bone enlargement of the distal and DIP and PIP joints, evident in both straps respectively. So proximal means boots are, and distal means evident. So OA most commonly involves the spine and in the large weight bearing joints of the lower extremities like knee, hips. Morning stress is more typical in rheumatoid arthritis like RA, but may experience for a short duration in patient with OA as well. So in contrast, morning stiffness in RA may persist for hours, so it may persist for hours and is often accompanied by symptoms like fever, weight loss, etc. They cause symmetric arthritis of the metacarpal PIP and other joints, but DIP is less. So, in contrast to bone enlargement in OA, the involved joints in RA have active synovitis with warm and spongy swelling. Fibromyalgia is characterized by diffuse musculoskeletal pain. So, diffuse musculoskeletal pain that worsens with weather changes, psychological stress, or reduced sleep. So, you know, there's just vague symptoms of muscle pain, myalgia. So, because of fibromyalgia. All right, so gout cause. Okay, now let's talk about gout. So gout cause episodic inflammatory monoarthritis that's characterized by a red swollen painful joint. It usually affects the first metacarpal joint, articulating joints, knees or ankles. So septic arthritis causes intense pain, swelling, or redness of the joint. The knee, hip, shoulder are most commonly involved. Finger joints are less often affected, and bony joint anatomy is not typical. So more about system signs are present. Reactive arthritis are cardiovascular arthritis when the knees, ankles, and feet, and is common in young men. Hand joint is not typical. So now let's talk about muscle proprioceptive organs. So muscle proprioceptive organs. So we sit for muscle. Okay. I think I need to. This is a long video. Let's just read this.
Right. Now we're talking about proprioceptors. So what is proprioceptors? What is reception? This is very important. इसके बाद यहाँ पे करेंगे आपकी मसल प्रोप्रियोसेप्टर। सिंपल क्या होता है कि आपकी मसल रस्सों की प्रोप्रियोसेप्टिव करेंगे, फर्स्ट आपका मसल क्या है, आपका यहाँ पर पोजीशन में बैठे हुए हैं, आप तो आप What's up?
Hi, Jira. We brought you here to
फाइबर और ये जो है आपको बताइए कि अगर डॉक्टर या आपने सिंपल करना तो इसमें आप जो मैंने कैसे नहीं हो इसमें आपको यहाँ पे डॉक्टर लूंगा या आपको लगा क्योंकि ये आप सेंस कर रहे हैं
Okay, again, this was the video.
आप इस मसल्स को लेकर क्या करा आपकी मसल आपको जो स्ट्रेच है उसको स्ट्रेच करें. अब ये आपका हो गया ये सेंसिंग मोड. अब यहाँ से क्या होगा बाइसेप आपकी जो बाइसेप है बाइसेप में जब आप वहां पे कंट्रैक्ट कर रहे हैं तो डेफिनेटली नीचे आपको बड़ा बाइसेप आपकी क्या करना है रिलैक्सेशन. अब इस केस में क्या है आपको क्या करना है साइमल्टेनियसली जब आपकी बाइसेप कंट्रैक्ट करेगा आपको क्या करना है ट्राइसेप की करवानी रिलैक्सेशन. और ये जो है आपकी किस तरीके से होगी इसमें क्या होगा ये आपको होगा इस मसल ने कंट्रैक्ट करना होगा इसको ये डायरेक्टली स्टिमुलेट करना होगा लेकिन इस मसल को हमने वहां पे एंटागोनाइज करना है जो आप वहां पे रिलैक्स करना वाले मसल को उसके लिए क्या होगा वहां पर आपको इंटरन्यूरॉन के थ्रू आपको एंटागोनिस्ट मसल को स्टिमुलेशन आपको स्टिमुलेशन देगा और ये स्टिमुलेशन जाएगी ये आपकी थ्रू आपका डायफ्राम न्यूरॉन ऐसा कि आपके एंटागोनिस्ट के बाद तो ये क्या करवाएगा और जब ये आपके जाएंगे एंटागोनिस्ट के बाद ये क्या करवाएगा उसके करवाएगा रिलैक्सेशन और ये आपके क्या करवाएगा उसको रिलैक्सेशन. ये आप क्या कर रहे हैं आपके मसल को और स्ट्रेचिंग को प्रोवाइड करेंगे आप क्या करेंगे एंटागोनिस्ट के बाद आपको एक करवाएगा रिलैक्सेशन. अच्छा ये जाएगा आपके आपके मसल स्ट्रेच करेंगे ये मसल स्ट्रेच ये बात नहीं बैकग्राउंड नहीं वहां से आपको आपके बाद अभी क्या आप देखिए क्या आपकी आपकी प्रोफेशनल रेस्टिंग होगी या फिर स्पीड ऑफ स्ट्रेच लेके आप देखिए तो उससे क्या होगा वहां पर न्यूरॉन वहां से आपकी जाएगी प्रोफेशनल आगे स्पाइनल कोड बात से क्या होगा वहां पर इनबिटवीन न्यूरॉन और जो आपके अल्फा मोटर न्यूरॉन है इसमें होती है एक्टिवेशन. अब ये क्या करेंगे इनबिटवीन न्यूरॉन जो आपके होगा एंटागोनिस्ट मसल को करवाएंगे एक्टिवेशन और कि आप इसमें यहाँ पर जो मसल स्ट्रेच है ना जो आपका मसल स्पिंडल है वो आपके रिस्पॉन्स को
Okay, let me just read it. So this is spinal cord, this is dorsal root, this is ventral root. So ventral root, dorsal root has sensory function, ventral root is motor and function. So ventral root has motor neurons which run hair and supplies a muscle which is via alpha motor neuron. So motor roots, motor nerves is alpha supplied by so muscle supplied by alpha motor neurons. So so see, this is a muscle spindle. This is spindle of a muscle. So here's this muscle spindle, here's a muscle spindle, and muscle spindle, and this is a tendon. So Golgi tendon organ is present in Golgi tendon. So tendons take the sensory pathway here and goes into the spinal cord interneurons. It goes into inhibitory interneurons. So Golgi prevents, supplies the interneurons, while muscle spindles, muscle spindle supplies, this is the muscle spindle. Muscle spindle goes here and via 1B sensory axon, and so Golgi tendon goes via 1B sensory axon, while muscle spindle goes into the spinal cord via 1A sensory axon. So 1A sensory axon and 1B sensory axon are two different types of axons. So 1A sensory axon, and so it goes here, relays in the dorsal root ganglion, and goes into the spinal cord and gives alpha motor neurons. So the alpha motor neurons comes to the muscle and helps in contraction. So you see, when muscle spindle or stretch fibers are muscle spindle or muscle stretch fibers are stretched, then it goes through spindle muscle through muscle spindle. 1A fibers through muscle spindle. 1A fibers goes into the alpha motor neurons, and and helps in stretching it, while Golgi tendon organ supplies via 1B neurons and supplies the interneurons. Okay, the Golgi tendon organs are sensory receptor located at the junction of the muscle and tendon. So Golgi tendon organ means it is present in the tendons. They are inhibited by group B sensory axons. So they are inhibited by group B sensory axons. Golgi tendon organs are connected in series with the contracting extrafusal skeletal muscle fibers. So they are connected in series. So Golgi tendon organs are here. So here they are present in series with contracting extrafusal skeletal muscle fibers. When a muscle activity contracts against resistance, so when a muscle actively contracts against resistance, so when a muscle contracts against resistance, so if there is a resistance and a muscle contracts to contract, and then the increase in tension is transmitted to the tendon. So the increase in tension, so called tendon, means tension is transmitted through the tendons, activating the GTOs in the process. In contrast, GTOs are relatively insensitive to change in the muscle length. So they're insensitive to change in muscle length. So stretch is mostly felt by my muscle spindles, while they are insensitive. The while Golgi tendon organs are more sensitive to tension rather than the muscle length, because the lengthening of that occurs when the muscle is passively stretched. This was primarily in the muscle fibers and not in the tendon. So lengthening occurs in the muscle fibers, therefore GTO is not stimulated when lengthening of the muscle fiber occurs. So 1B neurons from GTO goes into the to contact inhibited interneurons in the spinal cord. So it goes into the inhibited interneurons in the spinal cord, which in turn synapse with the alpha motor neurons that inhibit the same muscle. So then it synapses with the alpha motor neurons of the same that inhibit the same muscle. Thus, Golgi tendon or circuit is a negative feedback system that regulates and maintains muscle tension. So it helps in maintaining muscle tension. When muscle exerts too much force, then GTOs inhibit the contraction of the muscle, causing sudden muscle relaxation. This prevents the damage to the musculoskeletal system. So, when a muscle is contracting against resistance, then to prevent more contraction of the muscle, then Golgi organ goes and released through the inhibitor interneurons into the alpha motor neurons, so alpha motor neurons, thereby decreasing the contraction of the muscles. Then A delta fibers. So what are A delta fibers? A delta fibers are thin myelinated fibers whose free nerve endings detect temperature. So A delta fibers. A means temperature. So temperature means tone. A delta fibers are thin myelinated nerve fibers whose free nerve endings detect temperature and nociceptive stimuli. So their free nerve endings detect temperatures and nociceptive. So pain stimuli and temperature stimuli is detected by A delta fibers, which are thin fibers. So A means early in the alphabet, so this is thin myelinated nerve fibers, thin but fast myelinated nerve fibers whose free nerve endings detect temperature and nociceptive stimuli. They are associated with sharp pain and constitute afferent portion of the reflex are the medius withdrawal from noxious stimuli, that is rotate the hand or away from the hot stove. So if there is pain or temperature sensations which can damage the body, then the reflexly the hands are withdrawn by A delta fibers. In contrast to the in-series arrangement of GTO, so in contrast to the in-series arrangement of Golgi organs, muscle spindles, interfusal muscle fibers are connected in parallel with the extrafusal fibers. So in contrast in series, so GTO Golgi organs are connected in series, means one by one, line by line, while muscle spindle, that is intrafusal muscle fibers, are connected in parallel with the extrafusal fibers. So the extrafusal fibers and interfusal fibers are connected parallelly. They are inhibited by group 1A and group 2. So group 1A and group 2 sensory axons and a sensitive changes in muscle length. So muscle spindles mediate the stretch reflex, that is myotactic reflex, which is commonly tested deep tendon reflexes, so during the neural examination. So muscle spindles carries the sensory pathway is by 1A and 2 group type 2 fibers, group 2 sensory neurons. So when a muscle stretches, there is a monosynaptic reflex activation of the alpha motor neurons, so the same muscle causing contraction that resists the stretch. So there is, when the muscle is stretched, then alpha motor neurons of the same muscle is stimulated, causing contraction. So it helps in contraction, while Golgi organ helps in relaxation. All right, what is So now next is about pacin and corpuscles. So pacin and corpuscles are rapidly adaptive mechanoreceptors located in the subcutaneous tissue of the skin, as well as mesentery, peritoneum, and joint capsules. So joint capsules also has pressure receptors, which are pacin and corpuscles, mesentery, peritoneum, and joint capsules. Rufinase end organs are slowly adaptive mechanoreceptors that exist in the skin, subcutaneous tissues, and joint capsule. Both help to mediate touch, proprioception, and vibratory sensation are inhibited by myelinated A beta fibers. So rufinase end organs are adaptive, slowly adaptive mechanoreceptors that exist in the skin, subcutaneous tissues, and joint capsule. The both help to mediate touch, proprioception, and vibrations. Inhibited by myelinated. So vibration and proprioception are inhibited by myelinated alpha beta A beta fibers. Okay, so now let's talk about hip motions. Let's watch a video first. So
So guys, if you want a better understanding of the muscles around the hip joint, this tutorial is for you. Let's use our 3D anatomy model to show you the key muscles of the hip. Hey guys, Carl is here. Welcome back. So and S for 2 stands for subclavius. Now, one of the key thought processes around these hip flexor muscles that they want to have is secondary the most famous and most memorable hip extensor, and that is the gluteus maximus muscle. So, of course, when you're thinking about your hip thrust exercise, side, where we can see that the femur is now in a neutral position almost. We can see that this muscle runs totally along the back of the femur before inserting into this. Is the tensor fascia lata. Now, this muscle inserts or joins into the iliotibial band of the thigh. They insert into the superior facet of the great tricep of the femur. When we think of patients who have a gluteal tendinopathy, where they have pain around the little hip, it's thought that it's a tendinopathy of the knees.
Okay, so major muscles responsible for most at the hip. So flexion occurs because of flexion of the hip joint occurs because of the psoas muscle, rectus femoris, tensor fascia lata, and yeah, they are hip flexors. And sartorius also. Sorry, yeah, no, sartorius. Maybe a sartorius also okay, also in it. So abduction occurs by gluteus medius and minimus, and adduction occurs by adduction, adductor brevis, adductor longus, and adductor magnus. Extension occurs by gluteus maximus, semitendinous, semimembranous, and biceps femoris long head. Okay, major muscles when sitting up from the supine position include. So from sitting up to the supine position, major muscle when sitting up from supine. So after sitting, after supine position, while we start sitting up, so there is external abdominal obliques, external abdominal obliques, the rectus abdominis, and hip flexors. So hip flexors are very important. And rectus abdominis is important, and external abdominal obliques are also important. The psoas major and iliacus contribute more significantly to the hip flexion. They carry along the psoas minor, known as iliac psoas. So okay, iliacus and psoas major means iliac psoas. And the capacity of these muscles to carry out these motions can be deduced from the fact that they origin of the pelvis and spinal column across the hip joint and is saw on the femur. Psoas major muscle arises from the vertebra, from the body's intervascular disc of the inferior most thoracic and all of the lumbar vertebrae. So okay, psoas major rise from the inferior, from all the lumbar as well as the inferior most thoracic vertebra. The iliacus origin from the iliac fossa. Large concave surface found in the aspect of the ilium, both muscles insert via common iliopsoas tendon in the lower end of the femur. The adductor pluxor, a portion of the adductor magnus origins from the inferior ramus of the skin and inserts into the proximal two-third of the posterior medial femur. It's a powerful adductor of the thigh. So adductor magnus is the adductor of the thigh. So the longer the bicep femoris origins from the scale tuberosity and inserts into the lateral head of the fibula. So lateral head of the fibula. So it's a thigh extensor and leg flexor. Gluteus medius is the abductor, and so obturatus externus operates from the anterior medial surface of obturatus foramen and inserts into the lateral trunk of the femur. It's a lateral rotor of the thigh. So lateral rotation is occurs via obturator externus. So obturator externus means external rotation. So lateral rotation of the thigh occurs here because of it. The vastus medialis is a component of quadratus femoris. It arises from the proximal femur, ultimately inserts into the tibial tuberosity by means of patella. So vastus medialis is a component of quadratus femoris, so it helps in extension. So for approximately also the tibial tuberosity means of the patella. So okay, vascular arteritis has been discussed multiple times. So earlier headache, also pain and rapid response to corticosteroids and features of cancer arteritis. This is most common for vasculitis in person of northern Europe condition and occurs especially in patient age more than 50. Half will have polymyalgia rheumatica, which causes achy pain in the shoulder and hip girdles. This also confers high risk of thoracic aortic aneurysm, but not berry aneurysm. So our father's history is likely unrelated to her presentation. So father history of berry aneurysm is not related to her. So thoracic aortic aneurysms can be present in these years. RSA is characterized by T-cell mediated inflammatory process of large arteries. It may occur diffusely, but predominantly affects the arteries of the head and neck, especially the temporal arteries or temporal arteries, and occur. Bias of the temporal artery will also scattered. Focal granulous inflammation most pronounced in the media, and with intimal thickening, there will be elastic laminar fragmentation that forms without distinct granulomas. GCAs are histologically identical to Chagas arteries, which typically involves aortic arch and affects primarily younger patients. So they are basically Newman, the lymphocyte macrophage infiltration. So here lymphocytes and macrophages are infiltrating, multiple enzymes are also present here. Okay, alright. Hyaline arteriosclerosis is characterized by deposition of homogeneous hyaline metal in the intima media of the small arteries and arterioles, and associated with diabetes, hypertension, and advanced age. Severe hypertension also results in hyperplastic arteriosclerosis, which manifests as onion-like concentrated thickening of the walls of arterioles, laminated smooth muscle cells, and reduplicated base membrane. So reduplication of base membrane can occur. Both forms of arteriosclerosis can cause anorganic ischemic injury. However, the resulting symptoms or signs would not respond to glucose corticosteroids. So hyaline arteriosclerosis is here deposition of homogeneous hyaline materials occurs in the intima media of small arteries and arterioles. So and it's associated with diabetes, hypertension, and advanced age. So hyperplastic arteriosclerosis can occur in severe hypertension, only in like concentrated thickening occurs. And yeah, both homogeneous arteries can anorganic ischemic injury can also occur. So, hyaline arteriosclerosis is the arterial wall thickened by deposition of homogeneous eosinophilic material. So, this is homogeneous material that is thickening, the word thickening has occurred cause narrowing of the vessel lumen. Hyaline material is past positive or bright pink in color. Uric acid skiff stain. Hyperplasia arteries is only skin-like, concentric wall thickening occurs. Middle band-like calcifications are characteristics of Monkenberg's medial band-like calcification is a characteristic of Monkenberg's medial calcific sclerosis and present as pipe stem calcifications on X-ray. So pipe stem calcification on X-ray can be seen. They may be associated with atherosclerosis but do not directly cause symptoms and are usually not clinically significant. Okay, they are typically in Monkenberg's median calcific sclerosis, but present in pipe stem calcification are often X-ray, and may be associated with atherosclerosis, but they do not directly cause symptoms and are usually not clinically significant. Transmural inflammation of the arterial wall with fibrillar node necrosis constituting polyarteritis nodosa. So transmural inflammation. So all the layers of the wall can be affected with fibrillar necrosis. In polyarteritis nodosa, this uncommon form of vasculitis typically occurs in young adults and presents with independent episodes of a variety of manifestations including abdominal pain, peripheral neuropathy, renal insufficiency, and severe hypertension can also occur. Blood walls with fibrillar necrosis can be seen. Inflammatory cells in vessel wall can also be seen. Inflammatory cells can be seen in vessel wall. Blood wall with fibrillar necrosis can also be seen. Okay, buddies. Now let's go into rheumatoid arthritis again. Okay, this patient has chronic symmetric rheumatoid arthritis associated with severe morning stiffness and synovitis, swelling, warm tenderness, in association with the regular finding of joint space narrowing and marginal joint erosion. This is typical RA. Progressive autoimmune disorder that peak incidence at the age 50 to 75 or can occur at any age. Women are affected more than men. Systemic symptoms are also seen. Pathogens involves both humoral autoantibodies against citrullinated polypeptides and cell-mediated immunity active on the CD4 cells, especially TS1 and TS17 occur in the disease process. Macrophages release pro-inflammatory cytokines critical for the development of progressive arterial destructions in RA. This include TNF-alpha, stimulates the production of inflammatory cells and causes expression of inflammatory factors like collagenases, prolactin, prostaglandins by synovial cells. TNF-alpha stimulates the production of inflammatory cells and causes expression of inflammatory factors like collagenases, prostaglandins by synovial cells. Interleukin-1 induces synthesis. Interleukin-1 induces synthesis of matrix metalloproteinases and enhance T-cell immune response. So they induce interleukin-1 induce synthesis of matrix metalloproteinases and enhance T-cell immune response. Okay, so see, TNF-alpha stimulates inflammatory cells, and while interleukin-1 induces synthesis of matrix metalloproteinases and T-cell immune response is stimulated by interleukin-1. The proteases, collagenase, metal proteases contribute to cartilage destruction. So proteases will lead to cartilage destruction. In addition, both cytokines indirectly activate osteoclasts, resulting in bone erosion. So cytokines are the reasons for bone erosions. Monoclonal antibodies can inhibit TNF-alpha like TNF-alpha etanercept or interleukin-1 receptor anakinra are widely used in treatment diarrhea, but they are biologic demarts and will slow the progression of the disease. Activated T cell 1 cells activated helper T cell 1 cell produce significant quantities of interleukin 2 and interferon gamma. So to activate TS1 cell when activated produce interleukin 2 and interferon gamma among other cytokines. Although TS1 and helper T cell 1 cells and interferon gamma plays a role in pathogens area, interleukin 2 is not very much important. So TS1 cells and interferon gamma plays some role, but interleukin 2 is not very much significant. The cytokines are present in higher quantities in granulomatous disease like tuberculosis, sarcoidosis. In 4 and 5 prominently involved in muscle function, play a role in pathogens of atopic disorder like asthma. TGF beta, so transforming growth to TGF beta and interleukin 10. So TGF beta and interleukin 10 are anti-inflammatory cytokines. They are not inflammation, but rather helps in decreasing the rate of inflammation. So anti-inflammatory cytokines are TNF beta and interleukin 10. So interleukin 10 and TNF beta that downregulates skin activation proliferation and reduce the production of pro-inflammatory cytokines TNF alpha. So TGF beta reduces the formation of TNF alpha. The cytokines are likely produced by joint mutations in RA. Interleukin 12 and interleukin 23 are produced by activated T cells. So activated T cells produce interleukin 12 and 23. They are important in the pathogenesis of psoriasis. So in psoriasis, there is a disruptor is normal skin barrier, liability to trauma, infection, and genetics. And inflammatory cytokines release the interleukin 1 beta, 6, and TNF alpha. So inflammatory cytokines are released, and the activation of dendritic cell occurs. So T cells, so it's disrupted skin barrier occurs first, then T cells are dendritic cells are recruited, activation of dendritic cell occurs, then interleukin 23 is synthesized, interleukin 20 synthesized, which converts naive T cells because of 12 into TS1 cells, and because of interleukin 23, so TS1, so interleukin 12 stimulates TS1 cells, while interleukin 23 stimulates TS17 cells. Okay, and it is one secretes one gamma interferon gamma, leading to keratinocyte proliferation, and interleukin 17A and interleukin 22 leading to again epithelial changes. Acanthosis, parakeratosis, and hypokeratosis can occur. And epidermal changes occur because of it. So see, if there is any mucosal barrier or epidermal barrier wherever it is, then dendritic cells are activated. Interleukin 23 is secreted, which activates the naive T cells, and interleukin 12 activates naive T cells, and the T helper 1 cells are stimulated. T helper T cell 1 cells are stimulated by which they secrete interferon gamma and cause epidermal changes, while interleukin 23 causes stimulation of TH17 cells, which interleukin 17A and interleukin 22 stimulate epidermal changes in the skin. Antimicrobial peptides, interleukin TNF1, TNF alpha, and interleukin 1 beta again stimulates the interleukin 23. Now this is occurring bursa. The patient has student elbow, that is olecranon bursitis with localized swelling over the posterior elbow. So posterior elbow localized swelling means olecranon bursitis. The olecranon bursa is a fluid-filled synovial sac between the olecranon process and the skin that elevates or decreases friction at the bony prominence. Regulated pressure or overuse of extremities exercise can injure the bursa leading to synovial fluid accumulation within it. Bursitis due to overuse is non-inflammatory. So overuse bursitis is non-inflammatory. Also the difficulty and discomfort is typically mild. However, inflammatory bursitis like gout, rheumatoid RA infections can present severe erythema and pain. Bursitis, because the bursa is not an intra-articular structure, so it is not present inside the joint, bursa typically does not interfere with the joint range of motion. So there is normal pain-free range of motion unless it is significantly enlarged and inflamed. In contrast, intra-articular pathology like septic arthritis or intra-articular fracture in that both capsule, synovium, bone, and impaired range of motion between joint diffusion and pain, diffusion and swelling, not localized bursal swelling is typically present. So yeah, this is very understood. And the anal ligament encircles the radial head and holds it and the ulna together. So anal ligament holds radius and the ulna together. In children, ligamental laxity can predispose to a radial head subluxation, that is nourishment elbow. When axial fracture is applied to the arm, affected patients have mild tenderness in the anterolateral elbow, radial head, that is worsened by forearm supination. Swelling is not seen. So radial head subluxation occurs if excessively pulled, if elbow or radius is excessively pulled. So the triceps muscle originates from the infraglenoid tubercle. So the glenoid tubercle, infraglenoid tubercle. So tears from the head of the triceps originate from infragranate tubercle of the scapula and posterior humerus and inserts onto the posterior olecranon. So triceps originates from the scapula, that is infragranate part of the scapula and posterior humerus as well, and inserts the posterior olecranon, which helps in actions on the elbow. Okay, triceps tendon injury leads to pain at the posterior olecranon with elbow extension, and significant swelling will be atypical. Okay, so radial nerve. Radial nerve is the teres major muscle. Okay, is the triceps, long head of triceps, teres major muscle. This is here the quadrangular space, and below the teres major. Radial nerve comes out. Lateral epipendalis here. Okay, cutaneous small vessel vasculitis. I think I need to search cutaneous small vessel vasculitis on YouTube. Cutaneous vasculitis. Let's watch a very short video. All the videos are very long. I think I need to see this.
Here is normal skin in the bottom field. Please notice we have a loose papillary dermis, a thicker reticular dermis, and all of the classical layers of the epidermis from here to here. It is not uncommon for the papillary dermis, which is rich in blood vessels, to also have some occasional inflammatory cells scattered here and there, macrophages, perhaps a neutrophil, a couple of lymphocytes here and there. This is a normal population for inflammatory cells of the dermis. Let's take a look at this skin lesion on top, however. In fact, let's take a look at it by itself. Here we have it. This was a purplish.
So, okay, let's see the video.
Lesion, perhaps looking like a petechiae that was cut right down the center. So there's one half, and there's the other half. Notice there is no skin biopsy, and that was all in relation to the casual skin inflammatory cell. Okay, so that like that. This is like the pattern of stars. Like the stars.
Makes sense now. So, cutaneous small vessel vasculitis is a vasculitis that only affects the skin and typically arises due to drug or pathogenic exposure, for example, hepatitis B or hepatitis C virus. Drugs known to cause this condition include penicillin. So, penicillin, cephalosporins, sulfonamides, phenytoin, and allopurinol. These are drugs that can cause small vessel vasculitis. On skin examination, non-blanchable palpable purpura is usually present. So, non-blanchable purpura. So, if it was blanchable, then SSB vasculitis would have been the cause, but since it is non-blanchable, so okay. So non-blanchable purpura also occurs in HSV vasculitis. So this may be HSV vasculitis as well. It is usually present and often involves the lower extremities. When biopsy, this skin finding histology demonstrates markedly inflamed blood vessels with fibrin necrosis. In the first 24 hours of the perivascular inflammatory cell population consists primarily of neutrophils and fragmented neutrophils. They called leukocytoclastic vasculitis with mononuclear cells, which are predominantly nodal lesions. Okay, these are the cells. Erythema nodosum is a form of paniculitis. So erythema nodosum is a type of subcutaneous fat inflammation. The inflammation of subcutaneous fat that typically presents with painful erythematous nodules in the lower extremities. Okay, histopathology finding include widening of connective tissue septa. So there is widening of connective tissue septa due to neutrophilic infiltration. So connective tissue septa are widened due to neutrophilic infiltration and fibrin exudation, followed by histiocyte and cell infiltration with septal fibrosis. It's a form of paniculitis, inflammation of subcutaneous fat, presents with painful erythematous nodules in the lower extremities. Histopathology finding includes widening of front tissue septa. So there is widening of front tissue septa due to neutrophil infiltration. Because of neutrophil infiltration and fibrin acquisition, there is front tissue septa widening, followed by histiocyte giant cell infiltration with septal fibrosis. Giant cell vasculitis affect medium and large cell arteries, and typical presence is unilateral hair ache and claudication in age more than 50. Histological finding include focal granulomatous inflammation of the media and elastic lamina fragmentation. So this looks like this. So in elastic lamina fragmentation has occurred here. Okay, and yeah, polyarteritis nodules are there is transmural necrotizing vasculitis that affects small and medium sized arteries. Physical symptoms like fever, weight loss, and fatigue, renal failure, abdominal pain, or bloody stool due to ischemia of the involved organs. And this is PAN. This is PAN, polyarteritis nodosa. All right, bodies. Okay, subcutaneous rheumatic nodules. Subcutaneous rheumatic nodules appear as round form non-tender lesions that typically arise at pressure points. So subcutaneous rheumatic nodules appear as round form non-tender lesions. So they are nodules, but they are non-tender. For example, at the pressure point, like in olecranon process, and patient with advanced rheumatoid arthritis. Okay, and classic histopathology finding includes a necrotic center surrounded by palisading macrophage and lymphocytes. So there is a necrotic center, which is a necrotic center surrounded by palisading macrophages and lymphocytes. Okay, urticaria is often caused by medications. However, patients typically develop transient erythematous, raised blanchable skin lesions. Histopathology finding typically include superficial dermal edema with mild perivascular infiltrate, rarely neutrophils. So histopathologic finding typically includes superficial dermal edema. Superficial dermal edema can occur in urticaria, so with perivascular infiltrate, rarely neutrophils, and dilated lymphatic channels. So they look like wheels. Okay. Now let's talk about patellar fracture. So this is patella. It is a comminuted patellar fracture, and here is a fusion after the fracture. So the patient, some patient can have comminuted patellar fracture. So the patella is a large sesamoid bone that facilitates knee extension, protects a joint from direct injury, and improves nourishment of the distal femoral articular cartilage. So distal femoral articular cartilage includes nourishment of distal femur articular cartilage. Nourishment also occurs by this patellar joint, like patella. The quadricep tendon inserts the superior pole of the patella and wraps distally around the patella to become patellar tendon, which is the tuberosity. Patellar fractures are most common due to direct blow to the anterior aspect of the knees. For example, direct blow to the anterior aspect of the knee. For example, landing on a flexed knee in a fall, striking the knee against the dashboard on a frontal vehicle collision. The patella can also be fractured indirectly due to excessive force transmitted to the quadricep tendon. Like, for example, landing on a feet after falling from a height. Landing on a feet after falling from a height, patients develop acute swelling, for example, often with associated fusion, focal tenderness, inability to extend the knee against gravity, and pelvic gap in the extension mechanism. There's a swelling, tenderness, and extension of the knee is impaired because of patellar fractures and pelvic gap. So this gap present in the extension mechanism. The PCL protects against posterior knee movement and the least frequency under the ligament. This is positive, posterior rod is positive. Middle collateral ligament protects against valvular stress and MCL injury after lateral blow of the knee. And yeah, it we discussed before as well. Middle collateral ligament occurs because of direct lateral blow and anterior ACL tear. So anterior cruciate ligament controls knee, anterior knee movement, and ACL draw test can be done. Anterior draw test can be done. Okay, Lachman test can be done. Anterior draw test can be done. Lachman test can also be done. Lachman test can be done in the case of anterior draw test. Sorry, anterior cruciate ACL tear. Knee flexors include the hamstring muscles. So knee flexors of the knee, hamstring muscle, present backwards, biceps femoris, semitendinosus, and membranosus. So membranosus, biceps femoris, semimembranosus, gracilis, gastrocnemius, and sartorius. Hamstring injury can decrease hip extension and knee flexion. However, this muscle do not tend to the patella. So now let's talk about the last point of this lecture, which is selective estrogen receptor modulator. So SARMs include tamoxifen and raloxifene. Okay, SARMs are one of the most interesting compounds. Let's just see a little bit of this. Selective estrogen CRMs. Okay, I think this will do.
Welcome back. In this video, I'll be talking about selective estrogen receptor modulators. The reason I'm making a video about these drugs is because of how easy and important they are. So we'll be talking about tamoxifen, raloxifene, and clomiphene. These drugs are considered steroids or selective estrogen receptor modulators, as they have the ability to agonize estrogen receptor in certain organs and antagonize it in other organs. So tamoxifen agonizes estrogen receptor in one and organs. Raloxifene agonizes estrogen receptor in organs. So there is a case of both and preference. If I'm estrogen receptor in one organ, then I'm going to be able to estrogen receptor in one organ. Let's say I'm brain enlargement because of the intrinsic.
Okay, I think this makes sense. Tamoxifen and raloxifene. So raloxifene antagonizes red things like breast and uterus, while tamoxifen antagonizes just breast, not uterus and bone. So mechanism competition of binding, mix agonist action. So indication. Tamoxifen is used as adjuvant treatment of breast cancer, while raloxifene for postmenopausal osteoporosis. More action is occurs in the bones, and as for breast cancer. So for bone osteoporosis. Hot flashes are the adverse effect. Venous thromboembolism, endometrial cancers, uterine sarcoma can also occur. Amenorrhea, if the patient has amenorrhea and low bone density, there is a low estrogen state, so estrogen levels are low. This may lead to menopause, although exercise history such as possible hypothermic amenorrhea. Excessive extra exercise suppresses secretion of GNRs, leading to decreased release of FSH and estrogen levels. Because estrogen decreases bone resorption, estrogen deficiency in bone increases the risk of osteoporosis. Although estrogen replacement therapy that can mitigate the risk, it can increase the risk of breast cancer and should be avoided in patients with family history of breast cancer. In addition, unopposed estrogen, that is without concurrent progesterone, causes endometrial proliferation, resulting in endometrial hyperplasia and cancer. SARMs, relaxant are non-steroidal compounds that bind estrogen receptor and exhibit antagonist or agonist properties in tissue-specific manner. Raloxifene has estrogen agonist activity in bone, which decreases bone resorption, improves bone density, and has decreases the risk of body fractures. In addition, raloxifene has an estrogen antagonist effect in breast tissue and can decrease the risk of breast cancer. It also acts as an estrogen antagonist in the uterus and does not increase the risk of endometrial cancer. Tamoxifen is a selective estrogen SERM that has a strong antagonist effect. Tamoxifen has antagonist effect in the breast, so it's used in the treatment of estrogen receptor positive breast positive breast cancer. Tamoxifen, it has estrogen-like effect on the bone and reduces the risk of osteoporosis and most but it can cause endometrial cancer, not routinely used for osteoporosis. Bisphosphonates inhibit osteoclastic bone resorption. They have no estrogen agonist or antagonist activity, do not lower the risk of breast cancer. Leuprolide. Leuprolide is a GnRH analog that stimulates FSH and LH release. It's a GnRH analog which increases FSH and LH release and subsequent production of energy in a positive manner. By a programmable pump for treatment of aneurysm, but suppress release when administered continuously for endometriosis. So continuous use may cause reduce breast cancer. Continuous use may reduce breast cancer, but it has to do with accelerated bone loss. So MDP, so medroxyprogesterone progesterone, reduces the incidence of endometrial hyperplasia and endometrial carcinoma in a postmenopausal woman. So medroxyprogesterone reduces the incidence of endometrial. So progesterone reduces endometrial hyperplasia and carcinoma. And in postmenopausal woman on estrogen replacement therapy, but otherwise has no benefits in the osteoporosis. In addition, long-term use of medroxyprogesterone alone is used with increased bone loss. Compartment syndrome, this is the right leg cross section. There is anterior compartment. There's deep posterior compartment, is the lateral compartment. So anterior, lateral, and deep posterior compartment. So deep posterior compartment has tibial nerve and perineal, so perineal artery and veins, posterior artery and superior compartment. So there is a posterior compartment. The deep fascia of the leg, the facial intermuscular septa. So this is where is the located here. So these are facial intermuscular septa. Facial intermuscular and interosseous membrane divided into four compartments: anterior, lateral, and superficial and the posterior. The fascia is inelastic and limits outward expansion of the contracting muscles. If the pressure in the facial compartment increases, the circulation of this compartment becomes compromised. If the pressure in a compartment increases, the circulation within it can become compromised into pain and even tissue ischemia. This complication of compartment syndrome can lead to long bone fractures, cross injury, trauma injury, non-traumatic causes like bleeding disorders, vascular disorders. Ordinance surgical decompression fasciotomy of the involved compartment necessary to prevent permanent and disabling injury. The most common site for ACS is anterior compartment of the leg. So anterior compartment of the leg is very frequently affected, which includes foot extensor muscles, anterior tibial arteries, and deep fibular nerve. Injury to the deep peroneal nerve causes decreased sensation between the first and second toes, decreased dorsiflexion of the foot, foot drop, and claw foot. Injury to the deep peroneal nerve causes decreased sensation between the first and second toes, decreased dorsiflexion of the foot, foot drop, and claw foot. The great long surface pain is starting the roots of the foot. Okay, runs on the median leg and anterior thigh before merging with the common femoral pain and the femoral triangle. It is outside the deep fascia and is not vulnerable to ACS. Okay, the peroneal veins, a peroneal vein accompany the peroneal artery and drain blood from the lateral compartment of the deep posterior compartment. Okay, deep posterior compartment from the lateral uh, compartment into the deep posterior compartment and even in the posterior veins. The deep posterior compartment contains the posterior tibial artery, peroneal artery, and tibial nerve. ACS among this compartment may cause decreased sensation in the plantar surface, decreased flexion and pain with passage flow extension. And lateral compartment of the leg contains superficial peroneal nerve and the proximal part of the deep peroneal nerve. ACS nerve this compartment can produce loss of sensation in the lower leg and worsen the foot as the foot drop. Okay, finish. Bye bye guys. It was such a long journey.